if you're suspecting some other anomalies. Otherwise, in the routine case, it is not necessary.
No, ma'am, in routine cases, one added benefit if we get a CT scan done is we can know how the oval window is placed. If it is deeply placed, slight overhang of facial nerve is or dehiscence of facial nerve, or we can get to know whether it is an obliterative stapes foot plate or a simple annular ligament foot plate fixation. So all these information, okay.
But it's not really necessary as a routine, right?
Yes, yes, ma'am. Yes, absolutely right.
Now we are doing CT in most of the cases. So where you will place the impedance audiometry as a routine investigation, because it becomes unnecessary to do impedance then.
No, impedance has a great value addition because, you know, it tells the status of middle ear.
Yeah, but
When
anyway,
when we think only of stapes, we are not thinking about what can be the status of middle ear. There can be effusion in the middle ear also.
but that can be diagnosed on a CT.
CT scan, yes, of course, but the two things should be collaborating with each other to know that whether we are moving in the right direction. Impedance is basically a basic investigation which should be done because it correlates with the things.
I think we are really getting ahead, but you're right. I think impedance is the first to give you the idea.
Yes.
Thereafter, you should do CT only when necessary.
It can give us the status of eustachian tube. I mean, so many things. All 4 5 situations we can guess. If they're normal, we know that they're not associated other problems with this case.
Okay, right.
So it rules out things also.
You get on with your case now, please.
Okay, ma'am. Ma'am, CT we will be discussing. Please connect the CT. Just 2 minutes to show. On CT, what we see basically, what are the structures we focus on when we get a CT done? One is oval window, one is round window, one is facial canal, promontory for any hyperemic changes. I mean, then we do internal ear, which includes the cochlea, vestibule, internal auditory meatus, and the cochlear aqueduct. These are the things which we see on the normally for a stapes case. So we are just connecting the CT and show you, and then I'll move on to the case.
Right.
They're just connecting. So it'll be just patient has got it is totally prepared. Okay, now the CT is there. Okay,
Right.
So we are seeing both the ears together from above downwards axial cuts. This is the two limbs of the superior semicircular canal. We keep going down the subarcuate artery, appearance of internal auditory meatus. Now this is internal auditory meatus, labyrinthine portion, first genu, and it takes a turn back and becomes the tympanic segment. This is head of malleus, just body of incus showing up. This is the appearance of lateral semicircular canal. Now is the first genu, labyrinthine portion, first genu, tympanic segment. Now this is becoming tympanic segment there. Cochlea is normal, internal auditory meatus size is normal. And this is head of stapes, body of incus, we coming down, tympanic segment absolutely normal, covered. Now we are slowly approaching the site where we want to have our, I think this is one, I can increase the size, okay? This is the area of foot plate. Can you see there?
Yes,
This is vestibule.
Yes.
Now the stapes, okay?
Yeah.
So the thickness of stapes foot plate is not abnormally thick. So that gives me though it is not showing that hypodense demineralized focus which we see on the autosclerosis cases, but at the same time it is not does not seem to be an obliterative foot plate.
Right.
Okay, ma'am?
Yes.
So this is cut section of this thing, no head, the incus, and this is malleus.
Right.
So this is next cut is this is the pyramid.
Right.
These are the two crura.
Yeah.
So now we are going back, and this is the facial nerve. Absolutely at the right place. So important things we note, and I come to the round window also.
Yes.
Okay. This is the appearance of cochlear aqueduct. Can you see there?
Yes.
and there is this round window. So we don't find any autosclerotic focus there even. Can you see?
Yes,
Absolutely normal. And cochlear aqueduct also normal.
right.
So cochlear aqueduct.
Yes.
You can see there, this is at the base of cochlea, we find this cochlear aqueduct, which runs almost in the direction of interauditory meatus. So we can identify it close to just below the round window area, base of cochlea. And here, this is the cochlear aqueduct. It has three parts, basically: medial, mid part, intermediate, and lateral. The medial part is very important. There is a width of around 4.5 millimeter. If it is more than that, we can have a suspicion of widened cochlear aqueduct. Or at the midpoint, if it is more than 1.5 millimeter, again we can suspect. Then it correlates with the widened or the fundus of interauditory meatus is to be focused for any dehiscence. So everything is normal. No autosclerotic focus on the round window. So this should be a simple case. So it is purely a foot plate autosclerosis, no cochlear autosclerosis. Okay, ma'am?
On CT, is it possible to consider the thickness of the foot plate, if it's obliterative or thin
Yes.
foot plate? Can you predict that?
The normal thickness of foot plate is around 0.25 millimeter. But if it is obliterative, so we can calculate the thickness. If it is more than that, even up to 0.5 mm, so we consider it as a obliterative thick foot plate.
How sensitive this is on a CT?
No, it is more of a tactile eye. You get to see. Cone beam is better. These days, cone beam is becoming prevalent because it shows stapes in all dimensions and thickness of the foot plate. But on this CT, we can actually gauge it with the eyes. Though we can ask if we have a doubt. This seems almost a normal thickness of the foot plate. Okay. So if we are having some suspicion, we can sit with our radiologist and get it measured. How much is it?
Madhuri,
Okay.
what you said, normal footplate. Look at the footplate. The center of the footplate looks thinner than both the margins.
Yes. So this is a margins annular ligament, maybe annular ligament fixation.
No, you see what is the dimension of the footplate? So there's some probably autosclerotic foci in those margins. You see?
Yes,
why they're thicker? Why the margins are thicker than the center of it?
Yes, sir. This is annular ligament fixation can be there.
Ligament won't give you, unless it's ossified ligament, it won't give you bone window में दिखाई नहीं देगा.
Okay, so
दिखाई देता है bone, so that means it's a bone.
So you are saying that we may find obliteration at the margins.
Yeah, but you have enough space in the center for you to do fenestra anyway.
Fenestra, there are basically 5 kinds of sclerotic areas.
Now, if you see these margins properly, now posterior crura के आगे तेरे को जगह है, there you can do fenestra. You know what I mean? If you see anterior crura, that calcification is coming a bit more posteriorly. You know what I mean? But posterior
this is the area.
So this is the area. And second thing, which sometimes you can have persistent stapedial artery, which you can see if you have that. Okay.
We can see there.
Yeah. Now that was one of the role indication for CT scan is to exclude any persistent stapedial artery, which is very, very rare pathology. And but once you have persistent stapedial artery, you have to look for middle meningeal foramen. If middle meningeal foramen is missing, there's a dangerous sign. Then you should not be damaging the stapedial artery. Of course, either way, you're not going to damage the stapedial artery.
I think Dr. Satish is standing here. He must have come across some widened stapedial artery. Have you seen?
Yes, but you can have an indirect idea.
I told you wash up. I tell them one story about stapedial artery. Satish, in 91, I was invited to Madras to do a advanced otology course. And the first case was stapes. So the participant objected, there was some country called Dr. Ramdas. He had done many more stapes than me, So they said, why not Ramdas? So organizer came and told me, why not Ramdas? I said, of course Ramdas. No dispute about it. And as luck happened, there was a stapedial artery. मैं छूट गया. I seen only stapedial artery once. To put in my video, I borrowed the picture from ABR Desai.
New. I think देखो आगे.
idea about the something can't be picked up CT scan directly, and such a small. So how can you this artery can't started like this, enter through the stapedial arch, and then enter the facial nerve. So once there is a persistent stapedial artery, the dimension of the facial nerve, you see the facial nerve over here, the horizontal and the genuine, it is much more than the normal dimension. That is one indirect idea. Number two is about, like sir mentioned about the
Middle
meningeal
meningeal.
foramen. See, this is middle meningeal artery. That's the foramen spinosum. This is foramen ovale. This is spinosum. This is ovale. And this is foramen spinosum. Normally it leads to middle meningeal artery. During embryological life, if this stapedial artery is absorbed, this leads to middle meningeal artery. If it is persistent, there is no middle meningeal artery. And that people consider that the job of the middle meningeal artery, the supply where it normally goes, it is taken by the persistent stapedial artery to those areas. No, not completely. So earlier people would refrain from coagulating the persistent stapedial artery, as it may give somewhere infarct in the brain or some other areas. A lot of angiographic studies have been done, and ultimately it turned out to be safe to coagulate in case you want to. So you can do that. People can use, I have seen Ashish once using the piston besides the artery. He got reasonably good space and put the piston beside it and it worked. So depending upon the situation, you can take a call, but indirectly you can pick up from CT scan whether there is persistent stapedial artery or not. Absent is foramen spinosum and a dilated facial canal. These are two indirect ideas.
How long she is going to take to wash up? She is not washed up, na?
She is washed up.
She is not washed up. Has she washed up?
Yeah, she is washed up.
She is sitting on the table to operate. Otherwise, I'm going to show you post after this. First, Day1 facial now. I just operated on this Tuesday.
She is ready, sir.
How
She
difficult
is
it was.
changing to microscopic picture.
He's ready to operate.
Yeah, okay, later get on it. I'll show you this after her presentation.
Right.
After her surgery, rather.
Could we start, please?
Please, we can get on with it. Go to the microscopic picture. I show the Madhuri's beautiful face. ये गलती हो गया माधुरी, I didn't mean it. मास्क वगैरह से दिखाई नहीं देगा ना फेस, इसीलिए.
अच्छा थोड़ा ज्यादा हो गया, एक बार कर लेते हैं.
Are you getting microscopic picture now?
Yeah.
We are getting it.
So this is right here, sir.
There's no clarity. 1 minute.
अभी just a minute.
Sure.
She's just doing the initial cleaning part of the.
Right.
मैं तो फोकस पर आ रहा ठीक है, मेरा ठीक है, आपका ठीक है? The focus is okay for you?
Wash कर दे तो अच्छा लगेगा.
हाँ जी.
The local has been given already.
Yes, because we wanted the effect, because now I will just show it how we do it.
Yeah.
But local we have already given.
Right.
Though it is the patient is under GA.
Right.
But एक needle और वो दो.
200 to 250.
If any of-
Satish is in the theater, na?
Yes, sir.
हाँ
Yes, sir.
साथ है सर.
Satish, then look at the posterior superior compartment of the drum. Do you think it's thinner? Let a focus, then you'll be able to see.
Yeah. There is some blab on the, flap because of the infiltration.
Distance
That is bulging is there. You can see that. I'm talking drum.
Can you focus?
By God sir. अभी ठीक है?
Yes, yes.
बढ़िया.
Section छोटा दो.
नहीं, focusing
Whole
कर
section.
माधुरी. You are in the canal. That's okay. You are in the canal.
Yes.
No problem.
I am in the canal. Now local was given at 4 sites, 3
Can you
o'clock,
centralize
6
the-
o'clock, 9 o'clock and 12 o'clock.
Just centralize, please. No, it's gone off.
Oh my God. Oh, ये तो बिल्कुल heavy है बात.
Little up,
तू छोड़ रहा है?
not centralizing.
तू एक बार छोड़ मेरे को. Too good but too difficult.
अभी हो रहा है मैम, अभी आ गया है.
ठीक है, छोटा small size section.
If any of the audience want to ask any questions during the procedure, please feel free to ask. Huh?
अच्छा, okay, syringe then I can. We'll just the injection given is 2% ADR, 2% xylocaine with 1 in 2 lakh ADR. It was given at 4 sites. Needle लगा दो बस. So at the junction of bony and cartilaginous external artery canal, deep up to the bone, and there we give the local. We should not be giving in a superficial layer, otherwise it will raise the blood, which will obstruct our view for the surgery. So if I can
Madhuri,
see,
I tend to put more adrenaline. 5 cc, for example, I may put 5 drops of adrenaline
okay.
for infiltration.
सेंट्रल में नहीं आ रहा है.
My God. अभी गड़बड़ है क्या? So the locations are here. You can see vibrissae. This is the
Centering is
area
not
for
done. Centering is
Sorry,
not
no.
done. Reduce the
Sorry.
magnification. Reduce the magnification. You'll be able to
use
see
the
centering.
magnification. Do more. Okay. Is it no? Wapis.
Canal is seen nicely. Your canal is seen.
Okay. So this is location for the 9 o'clock. This is location for the 12 o'clock. This is location for the 3 o'clock, and this is for the 6 o'clock. Superior, anterior, posterior, inferior. Okay. So now already the local has been injected. Now we come to giving the, because this is a wide canal, we are opting for endomeatal approach and endomeatal raising of flap only. Many a times there can be a narrow external artery canal, then people can go through the endoral approach. But I usually have never required for any endoral approach for the stapler.
Germans are fond of doing endoral approach, which has been taught to in India by Dr. Pusalkar. So there's nothing, because then your 2 hands are free. So I think for beginners, there's nothing wrong in learning that approach. But most often you can do the surgery with this approach.
Okay. So now giving the incision. Acha. So almost 9 mm to 1 centimeter lateral to the tympanic annulus in the posterior canal wall at around 9 o'clock on the right side. I will start the incision with a circular knife.
Dr. Madhuri,
Yes.
do you use speculum holder at times?
Speculum holder.
Yes.
I tried it, but honestly, I could never feel comfortable with that. So I have taught my staff only to hold it when I am doing the deeper in the work in the middle ear. Otherwise, I hold.
My boss, Dr. Kayusha, used to always use a speculum holder. So I bought one. I never used it in my life and I lost it.
Yeah, Dr. Mahadeviya also gave, he also, I think he created a speculum like that. So this is going around superiorly and inferiorly. Inferiorly as I go down, 1 minute. This, sorry, bear with me because this is slightly a different microscope. Okay. So up to 6 o'clock, I'll take this incision in one go in the same plane. Superiorly as I go, the soft tissue is so much beneath the skin that I have to use some extra instrument. One thing is I will take it slightly medially as I go anteriorly and superiorly. And for this soft tissue, either I take a 11 number knife or a scissor, because otherwise I'll be tearing through the. Achha.
You can bring your lunch. You can have afterwards.
circular 9.
इधर 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 ये बस देख क्या खाना दे क्या मांगते हैं इसमें से
So as I go anteriorly, I start going slightly medially, and I have to reach at least 2 to 3 millimeters anterior to the neck of the malleus. Why? Because we all know we have to see for any fixation of anterior malleolar ligament. इसको अच्छे से-
Madhuri, how often have you found fixation of annular ligament?
Sir, at least 1 or 2% cases I have found them. As I was telling you, sir, I have found other ossicular malformations also, like anterior crust missing but footplate mobile, and long process of incus, rudimentary footplate mobile, and anterior malleolar fixation. So many varieties are there.
Hugo Fish used to give a very big number of anterior malleolar fixation. That's why the question is asked. Unfortunately, I never diagnosed it. And whenever you go in the step, it has happened to me that we diagnosed autosclerosis clinically. And when you went in, your footplate was mobile. So you're given up. In that era, we did not know anything like anterior malleolar fixation. So we've not done a surgery also. As a 3-4 cases
पकड़ना पड़ेगा।
happened to us like that.
No, थोड़ा इधर।
Probably there were the cases of
थोड़ा
anterior
कम
malleolar
push
fixation.
करो। Towards this side, no, less. Because we are still outside, no? So we shall be lifting it together, not in pockets. इधर लाओ। Oh my God.
What she's telling you, we are elevating the skin, make millimeter all along. Don't go 3
Give me a
millimeter
side
one
line.
side or 1 millimeter other side. Then there's a chance of tearing the flap.
एक इससे भी छोटा section दो. And at 6 o'clock, I'll make a release incision.
Like Ketan makes it at 5 o'clock. There's nothing wrong about 6 o'clock, 5 o'clock. He says the pathology in superior compartment, why should I go up to 6 o'clock?
So maybe on the right side, 7 o'clock, है ना?
Whatever, yeah. So you don't have to
And on
go.
the left,
Yeah, but
on
by
the-
giving 1 millimeter extra incision, you're not going to do any harm anyway.
पकड़ो इसको. Hold it. Circular. थोड़ा नीचे ले लो इसको. We are working here, तो यहाँ ले आओ. हाँ? This microscope cannot be moved too much, so
Microscope को arthritis क्या है?
huge. फिर से नाइफ में है।
You want to be like a head and neck surgeon, they work with Tata. That you need a लड़की के लिए मुश्किल है बहुत पेपरबाजी करनी पड़ती है अभी बॉम्बे में बहुत लड़की
Is that
ज्यादा प्रोडक्ट ऑल ऑफ दैट पहले जब हार्डली नहीं ओवरऑल मेडिकल कॉलेज
what of it?
बिल्कुल बैचलर 150 की बैच में 125 लगती है फर्स्ट ईयर
Okay, circular.
करेंगे हर
Someone is holding speculum for you, ma'am.
Yes, yes.
all three possibilities.
Like this.
Madhuri, what advice would you give the youngsters to avoid tearing of the flap?
So we must go very gentle. Our strokes should be with a circular knife, hard on bone, but gentle on the flap.
On the
The
flap?
movement should be, yes, movement should be hard on bone,
Yeah.
but very with the back of the circular knife, just push the soft tissue there.
But the main problem occurs at the annulus.
Annulus, yes, ma'am, yes.
So how would you minimize the chance of a tear there?
So that's why we must go lift the whole of the flap together
Ah.
rather than lifting it in. No, yes, sir. Yes, very good. So we try to enter the middle ear from inferior side.
Yes, I think that is a very important point.
Yes.
So that you don't.
We
have
don't
any-
enter, yes, may not cause trauma to the cauda or the ossicle, the chain. And another important point is shift over to a smaller section, ek size or chota de, so that we don't tear through the annulus
Yeah.
So
area.
the rough rule is 18 number section cannula once you're in a canal. 20 number when you're in annulus. If you are on the foot plate, it should be 22, 21. This is rough rule. But it depends also on the power of your suction machine. You see, this is rough rule. Rule of thumb, you can say.
फील ठीक है बहुत बढ़िया थैंक यू वेरी मच So slight time spending here is worth it because we don't want a tear in the.
Once you lift a portion of the annulus,
Then it becomes quite easy. Huh?
yeah.
ये छोटा smaller circular knife is there. अच्छे से पकड़. Just hold on.
Any questions from the audience you'd like?
ये tear हो रहा है आपने छोटा देश मेरे वाले में.
There's a question here. How many stapes are there in your institute in 1 year? Approximately.
I think around 4 or 5 in a month.
4 to 5 in a month.
5 to 5. Huh. To
Right.
be precise. I don't want to be.
No, I understand.
Madhuri, tell them how many ear cases you do per month. 50,
Per-
60, 70?
Per day in per OT, I do 5 to 6 ear cases.
Okay, this is what Madhuri is. Okay, but she is respected so much in that country or city and whole Haryana. How many cases of OPD do you do in private practice? About 100?
100 I have to stop because I don't have capacity beyond that.
So today, if you want to do a fellowship, there are 3 good centers. One is, of course, Satish Jain, the volume is tremendous. The second center is Madhuri Center. Janki Raman is good, but he doesn't do much of course, he does autology. It's not that he doesn't do autology. But these are the 2 centers which are good center to do a fellowship. उधर हाथ लगा के नहीं आने का, जाने का तो 3-4 महीना रहना चाहिए. You see?
Off कर दिया मैंने.
I used to go on weekends to her place. Saturday, Sunday, we used to operate about 25 cases. 2 tables. Some institute do not operate 25 cases in a long time. Same story was Satish Jain. उधर तो जास्ती होता था 30-32 केस.
Satish has much. No, don't down. Please. बता दो मेरे को पता नहीं चलना इसमें. Is it central? Picture is okay? Okay.
Yes.
So you can see the fibrous layer of the chota sickle. This is too big. Another sickle, please.
You find the sickle the best to lift the annulus?
At the annulus, once I have separated the annulus, then a small sickle, not the big one with the
Right.
big curve. So we have kept a small sickle with us like this. Can you see?
Yeah. Let her just remove it.
Can you see this, the fibrous layer?
Yes.
And the mucosal layer,
Yeah.
I have to separate it there. Now
Madhvi,
I am in the middle.
yeah. Madhvi, the picture needs to be centralized
Okay.
and focused a little better. Thank you.
Is it okay now?
No, a little down. No, it's too high.
Okay, okay, okay.
It needs to a little more,
Okay.
a little up, up. Yeah, up. Little up.
Dr. Satish,
Sorry, I'm
Satish
announcing.
told
some-
me.
Sorry,
Now
sorry,
it's
Madhuri, I'm just saying, can you get up? He does 150 stapes every year, 60 ear cases every month.
Chalo.
If you want to be a good otologist,
They're
हाँ, तो
focused.
भी-
and he's only DORL. He's not done MS, he's not done
Better है?
DMB. But he has worked more than adequately before practicing.
Right. Sorry, the focus.
हाँ, focus is.
Focus.
Wash करो एक बार अच्छे से.
Nahin. It's focusing on the canal rather than the
तुम छोड़ो.
middle part. It's again gone down. Sorry, the centralization is not good.
This. Okay now?
Yeah, now it's okay.
चलो.
Now it's
अभी
fine.
wash करना. We will wash this area so that we must not enter into the wrong direction.
Right,
Okay, small. बस. थोड़ा सा बस. Okay, perfect.
Hello, Dr. Madhuri.
Yes, sir.
Have you done the white balance for the
I
camera?
don't know. White balance इसका हुआ है क्या? I don't know. Let me ask them.
Otherwise, do it again.
अच्छा, somebody can come and do it.
You don't like to use adrenaline gel forms?
Usually I keep it to the minimum because when I require, I rather wash the area.
Okay.
So what I'm trying to do is if there is a corda, I can lift it with the flap so that it stops coming in the way. So can you see
Yeah, we can see the
the
income
reflected?
as well as the malleus.
Yes. But this is deep-seated corda, so I have not been able to lift it with the flap. Otherwise, we try to lift it with the flap so it stops coming in the way. So I will focus in the middle ear. Is it okay? Can you see the
Yes, so far good.
side knife? So now, whenever I am using this sickle, now I have to be really very careful because sickle can cut through the flap easily. So just use it in a very gentle manner. And whenever I have a doubt, I'll shift over to the side knife or flag knife. Now, inferiorly, if I feel that I can cause a tear, I'll just use a side knife. What am I inferior? I want to lift the inferior. Is it central?
Yes, it is centered.
Okay. So up to 6 o'clock, we will lift it and then pull it anterior. Put it anterior. Okay. Now it is out of the way. This
Little
much is
out of
good enough.
focus. Can you focus it, please?
Okay. Is it focused now?
Yes.
You are at the canal now,
Yes.
or flap.
Central now. Now the flap is anteriorly pushed, tucked in anteriorly. Okay. Now it is not coming in the way. Now we focus our, now once we lift the flap, the most important thing is we have to check the movement of the handle of neck at the neck of malleus. Give me pick. Is it focused for you?
Yes.
Okay. हाँ नहीं कोई भी दे दे sharp instrument. So if it is mobile neck of malleus or malleus itself, then I will not go further anterior. Okay. So I
Yeah.
don't have to keep lifting the flap unnecessarily. It is mobile. Can you see?
Yeah, we
Yes.
can appreciate.
So I will just stop my lifting of flap here only. Okay. So it is nicely mobile. Can you see?
Yeah.
Now our focus shifts to the lateral meatal wall or lateral scutal wall. Different people do different kind of, drilling or lifting it with scooping it out with the curate. What I do is I use a diamond burr of around 2 mm. No, diamond burr of around 2 mm. Give me one sharp instrument. I want to show the posterior malleolar ligament to be differentiated from the cauda. Can you see this tag there?
Yes, we can see.
This is the posterior malleolar ligament and it is not cauda. Cauda goes medial to the neck of the malleus. So this can be separated. Okay. Drill of 2 mm diamond burr. So I will first thin this wall, posterior meatal wall, and then scoop it out with the curate. Drill. So the maximum till they get the drill, we can discuss about how much do we expose for a case of stapes. If we talk, once we have drilled this ledge out, we shall be able to see the neck of malleus superiorly. Up to long process of incus posterior superiorly, body of incus should not be visible. That means we have drilled the attic wall. And if we are exposing the body of incus, we will have to deconstruct it with the partial thickness cartilage. So better don't expose the body of incus. If we come further posterior down, then base of pyramid is the outermost extent to which we can expose the area. And going downwards, the round window should be nicely exposed. So if we go in a posterior curvilinear manner, neck of malleus, long process of incus, base of pyramid and the round window in a arch-like fashion. Okay. So that we are able to see whether this stapedial movement is being passed on to round window or not. So drill ho gaya? Dena? Dr. Patil?
Yes, madam.
So you there?
Yeah, I am here. I am talking.
Okay. So the hyperemic bone or the mucosa can be seen around once I expose it. It is a typical presentation of a stapes fixation. You must have also. Okay. I am focusing on the bony ledge, not in the middle ear. Okay.
Little centering, please.
Acha, okay. Is it okay?
Better. Yes.
फुटपैड कौन सा है? ब्लैक वन कौन सा है? This one, this side. This is striker drill.
1 minute, ma'am. Diamond by all photo.
Let me see the size. Now, this is slightly a bigger size. To take 2 mm bar and take it out slightly more. The length of the burr shaft should be slightly more because we are working in the deeper inside. This is striker drill. I hope.
Madhuri,
Anji sir.
other day, Amol was doing a stairpiece and
Okay,
he
sir.
used a skitter burr for this. 0.6
Is-
millimeter skitter
Okay.
burr for overhang and
You're
0.5
right.
there's a cutting because the skitter, the handpiece is so thin. You know,
So thin, so
yeah.
easy. इसमें भी
So
डाल सकते हो.
you have
can
a
put-
skitter, you know.
If you give me this, I can do with this also. But
Yeah.
yes, that's because
I use angle handpiece as Madhuri must be using, but I thought the
Yes.
skitter was definitely better or much thinner.
Yes, sir. उसकी speed भी थोड़ा it is less. I think 2000. What is the RPM for the skitter drill?
1000.
1000 RPM. So it less chances of injuring the deeper structures.
Whatever, it was so beautiful and it
So
did
you
not
see
take
that?
time to drill it out. I'll be showing his case which he done for me on Tuesday with the overhanging fashion now.
So this is the skitter drill. Can you see, sir? The
Yes.
burr. Is there some bigger burr for this?
माधुरी उससे काम हो जाता है 6 मिनट रहे ये उसे हो जाएगा
और क्या?
1 मिलीमीटर की होगी तो भी हो जाएगा काम
हाँ वो थोड़ा है तो चलो ठीक है. Speed is very low, sir. No, it is not working. It is not working. मेरे को वही भर दो एक बार. तब तक आप इसको कर. You give me this one. 2 mm bar. Till then you prepare that skitter.
दूसरा मैम वो दूसरा बार है वो दूसरा
यही है ना?
हाँ जी.
ये थोड़ा छोटा नहीं. So I have to be conscious that I will not be exposing the body of incus. So my drilling will be slightly in a lower part. थोड़ा डाल. थोड़ा बस नहीं डालो नहीं डालो. ये थोड़ा बाहर निकल सकता है. इसको थोड़ा बाहर निकालो. ये चल नहीं रहा है क्या? चल देखो मूव ही नहीं कर रहा. थोड़ा जल्दी करेंगे. फास्ट चलो उनको बुला लेते वो देख लेते. This is giving a bit of trouble to us. Please bear with us for a few minutes. Drill is not functioning. इतना टाइट नहीं होता है. Let her do this. This can be done very gently. You do it, please. Where is the lady who is doing this?
Can you focus it bit?
पकड़ो. Yes, yes. I'll do that. लो पकड़ो इसको यहीं पे. Okay.
Now you have shifted to regular gear motor.
Yes.
That is better.
What is the
This is-
size of this burr?
This 2 है. ये 2 है. So 1.5 भी दे सकते हो लाइट में. अच्छा 1 है. 1 देना है.
By drilling, she is weakening the strong overhang and then it can be curated.
Yes, yes, absolutely right. Give me sickle, small sickle. Right, thoda बढ़ाना.
You show one case.
I am separating the cauda from there. Curate.
Yeah, I have. But I'm not able to. I had explored it.
Yes,
Then I tell you why, because she's the last.
You have to use it this way.
Yeah.
This way, you listen to it. The tip should not be.
Okay, 1 mm भर दो. Sickle.
I don't use it.
Tomorrow you can bring it if you are here.
I can bring it, but I'm not sure. I'm not.
Okay, you're saying.
बस नहीं डालना. Curate.
Then you
Yeah, yeah.
like this. I would like first thing. You try to expand.
Hmm.
You see, you are seeing like this. And at this angle. Now, if you stand at this angle, all right, you can see much more.
Sickle.
Okay.
फिर से वही दो 1 mm वाला बार.
Yeah, yeah.
थोड़ा लंबा चाहिए, बिल्कुल छोटा है, क्या करें इसको? दिखता ही नहीं.
And
फिर दिन. पानी डालना है. बस okay. Curate. Suction. Fast. नहीं वही सेम साइज फटाफट. Fast. लगाया. Sickle. अच्छा अब मेरे को दो वही ड्रिल दो.
Madhvi,
Hmm?
what is your end point for drilling the posterior superior head? No, no, I know.
Posterior superior only up to the long process of incus, curate. And
No.
posteriorly up to the base of the pyramid.
Base of the pyramid.
Yes, sir.
Okay.
Sickle. The cauda is in this case is really at the wrong place, totally in the middle.
What is
Hidden
it?
under heart.
What is at the wrong place?
Cauda is literally coming in the middle.
Corda. Right.
So, and it is hidden under thick bone. So I have to take care just to
Yeah.
avoid causing trauma to it.
Madhuri, when Madhuri,
Yes, sir.
when corda is in middle, I mobilize it superiorly.
Okay.
Instead of doing it inferiorly, na, sometimes it's easier to hide it under the bone once you curated adequate bone.
Okay. So let me try. Iska?
Yeah. Well, and sometimes if you mobilize it further anteriorly under the malleus, then sometimes it
Light
comes down.
बढ़ेगी कैसे? हाँ. Okay. Let me try.
लाइट बढ़ाना
हाँ. Deep में गए ना?
अभी
ठीक है. So, okay, now I'll check the movement of the stapes. ठीक है, Siddharth?
अभी ठीक
So light काफी कम आ रहा है. Can you see this head? Okay, slightly more curating is made.
Want to do a fellowship then.
Can you see the head of stapes fixed?
Yeah, we can see the mobility of the incus.
Done it already. Then doesn't need to do a fellowship.
But the cauda is still in the way. ये section खोलो. Light काफी कम आ रहा है.
Oh, right. So then this is, she should just go and observe a few times.
Section change करना पड़ेगा.
That will be good. But it's worthwhile going to him. You see, red, it's you see, but you don't get hands on. Yeah.
काउंटर्स कितना गया अंदर
Has she come?
Wash करो.
Oh, there's
थोड़ा.
Yes.
बस.
Definitely.
थोड़ा.
I agree to I have it.
Then it is easy to where do you simple.
अब इसको ऐसे
I
करो.
don't think I gave it to her
You have
yesterday.
to create a measurer देना फिर हमको नापना.
So are you going to take it up the corda?
I'm trying to think. I shall be keeping it because just wanted to check this bony ledge needs to be drilled. एक बार drill दे मेरे को. This is coming in the way.
I think what Dr. Modwani said seems to be
Right.
Yes.
But once I take it back, so it seems to be blocking the view for the foot plate area. So this basically this is burst size is quite small. I am unable to see beyond that.
The other question I'd like to ask you, when you change the position of the patient, does the view makes a difference? Like if you turn the patient towards you, you'll probably
When
see.
Yes. Of course, when it depends how in which way the foot plate is placed. So if it is a slanting suprastructure of the stapes, then we don't find much of the problem. It happens when it is deep seated or a straight stapes, deep seated foot plate. Okay.
Yeah.
So take it now.
Just centering it a little up. You need to bring it up, please. Still up.
Centering.
Yeah, okay, that's fine. Focusing also, please.
I'm trying to
Yeah,
fix it on the foot plate now. The sickle though? Yeah, pick de.
Okay, better now.
Curate de, curate pen. So I'm trying to remove this bony ledge so that I can see the,
Oh gosh. Yeah, that's better. Actually, this is the place where a Wilson's punch is very good.
no, pick. इसको ऐसे लो, हाँ ऐसे, ये hold up. Pick देंगे?
It's like that, you know.
No, this is needle, this is not pick. So I have confirmed this shown that incus is moving, but head of Malleus stapes is not moving. Okay, so now because this is the foot plate is clearly visible there. So what I'll do is I'll make a fenestra first. For that, I will measure the distance length of the piston. Now
Yeah.
piston length is measured.
So you're going
Is
to
the-
leave the border like that just now.
If I take it back now,
It will block you.
it starts blocking the.
Right, right.
Then
Right, I understand.
it blocks my foot plate area.
Right.
Drill दो एक बार और। The length of the burr is very short. Correct? Suction change करें.
Vincent.
Like this.
What a canal.
Okay, give me. Pick नहीं.
Then you can move it anyway.
और सिक्कल दो. छोटा वाला. I think I'm going to keep it anteriorly only. So as Morwani sir was saying is absolutely right. If you can, I will focus on the foot plate. Are you able to see the foot plate there?
Yeah, we can see.
Yes.
So as sir was saying, the margin annular ligament is badly obliterated, and the center there is blue foot plate only.
Yeah.
Okay.
So it's a thin foot plate.
Can you see? Ah, yes.
Yes, yes.
Margin is thick, but the foot plate is blue.
Right.
Okay. So
Yeah.
what I'll do is first I'll measure. I have a course measurer. Fix it on 4.5. So this is a measurer from course company only. This does not have the bony ledges as in the traditional.
Right. But the centering is gone again. Yes.
Is it okay now?
Yeah, better.
अच्छा okay 4.5 पे fix करना.
Actually, with a speculum holder for
So I'll show what this instrument is.
the speculum holder.
Speculum. ऐसे. Ma'am. Can you see?
Yes.
Yeah, we can see.
Yes, we can see.
So this is a course measurer. We have fixed it at 4.5. Basically, we all know how we calculate the distance. It is FID. Foot plate incus distance starts from the center of foot plate to under surface of the medial surface of the incus. So as we cannot go plus 0.25 thickness of foot plate and 0.25 thickness of entry into the vestibule. Okay, ma'am? So
Yes.
because we cannot go on the medial side of the incus, so we take the half thickness of the incus
Yeah.
for 0.25 and full thickness of the incus long process for the complete 0.5 mm addition to the distance what we are, okay? So rather than calculating it from the medial surface of the incus, we will calculate from the lateral surface of the incus. That way it will tell us the accurate size of the piston. So I'm keeping it there. Foot
Yeah.
plate. Okay.
You're measuring it now.
I am measuring it and I'll show you what this is.
Yes.
Zoom out. Dora. So this is the measurer we have. Can you see there?
Yes, we can see it.
So there's the numbers there.
No, we can't see it now. It's below the level.
Is it possible to see
No,
now?
hold it up.
No, no, centering is
No.
not there.
Centering is higher.
Now we can see.
Yeah. Now we can
Okay.
see.
So you can see this is the size we can measure from there by moving it.
Right.
Okay. So we
Yeah.
fix it at 4.5.
Yes.
Can you see there?
Yes, we can
Yes,
see
yes.
that.
So 4.5, it has got only one bony projection there. Can you see there?
Yes.
Yeah, yeah.
So
Yeah.
it measures the accurate distance. And because we have added the thickness of incus, which is around 0.5, so we have accurately measured, it has come out to be 4.5.
Right.
So usually most of the times, 80% times it is 4.5 for my cases. I don't know, you people can share. What is the usual size you put in your cases?
Okay.
Piston size. Can you, can Dr. Patil or ma'am, you can comment or sir? What
Yes,
size
absolutely.
usually?
Dr. Patil.
Yeah, we usually 80% times 4.25 and
Acha.
but better to measure every case. And minimum was 2.5 mm.
4 point, what is your minimum size?
2.5 mm.
2
And
point?
yeah, in one patient. Regularly 4.25.
4.25.
Yeah.
Yeah.
Okay. And the maximum?
Maximum was 5.5.
5.5.
Oh, really?
Yeah.
Acha, okay, I want to ask a question because I asked from the company also.
Yeah.
We always measure between 4.5 to 4.75. At times in one case, I had 4.6 also. So in this case, I didn't know why they don't make any piston between the two sizes. Did you ever have that problem? So
And the
मेरे को अब वो दे दो.
piston company usually makes 6 mm length. Okay. But the piston company makes 6 mm length, maximum 6 mm.
No, between 4.5 and 4.75.
Yeah.
Between that.
But usually the jigs are showing up to 5 mm, madam.
No.
So 4.75.
Accurate दो एक बार.
7. 4.7 she's stalling.
She had one case 4.6.
Yeah.
Okay.
ये दिल देना.
In between is you don't have, right?
Then
एक
you
size
cut,
बड़ा करो.
you cut it
इसको थोड़ा
approximately.
बाहर निकाल सकते हैं क्या? निकल रहा है. No, ma'am, no, it won't lock now. It won't rotate. इसको क्योंकि दिखता नहीं है.
There is a question, Madhavi.
Okay, ma'am.
They're asking why you're not removing that little bony ledge.
I am doing that only. Because ma'am, this length of the burr is not that much. I am unable to see beneath this. I cannot change the length. It is obstructing my view, so I am being careful because order might go if I am
Right.
not careful.
Right, understood.
So this is not showing me because I have to put whole of it inside. Accurate. Order might get sacrificed. I am worried.
Yeah. You tried
But-
separating the surface of the quadra from the undersurface?
I am trying, but
wheels
this
or
is a very thick bone. And when I drill there now, So I am unable to see the cauda beneath it. मेरे को वो curate दो इतना.
Is it going into the canal there?
Yes, ma'am.
Ah,
Very thick bone.
right.
Is a male patient now?
Yes, yes, sir. Hefty male patient, 48 years old.
Why male patient is thick skull? Woman should have a thick skull, no?
Thick. So it is the brain which matters, I think, sir.
And it is true, women have better brain than men, whether people agree or not. We may do jokes on the females, but females have better brain than men. That's why they need a thick skull to protect it more.
ये बदला section बदला गया. Time नहीं करना. This is quite thick. Section ready. Curate.
Now it seems to be a little more mobile.
Yes.
You've removed quite a bit of the wall now,
Now
Right.
it seems better, but
covering
Sure.
the border.
yes, ma'am. देना drill फिर वो दे दो curate दो फिर एक बार. So because you're right, the foot plate should be completely visible.
Yeah.
No. Okay. Drill.
Center it a little
Patient out
more.
आ रहा है क्या? Patient is out. Section. Many a times, cauda is easily can be separated. Few cases really give you trouble. You try your best to save the cauda. Then
Right.
curate.
Now you are seeing enough of the foot plate?
Foot plate, yes, ma'am. थोड़ा सिर ऐसे.
Dr. Robert Vincent, he uses a special hook to open the chorda canal, and then it
Okay.
becomes very easy.
It is a this is separate special
Yes,
instrument.
yes,
To
yes.
cure it, then,
He has made it specially.
Oh, great.
Who has made it? Who has made it?
Dr. Robert Vincent cost me.
The one we are talking about.
Now I think I have opened enough.
Robert Vincent, he said.
That
Because-
special hook is available outside. Made in
really?
India. It is available with Santosh. It is just a strong hook with a triangular pointed in the front. It is available there. We have been using for a long
Okay.
time.
Okay.
Robert Vincent is hook.
Wash देना. बहुत थोड़ा सा
He
दो
calls it as a decompressing the corona.
बस. He calls it decompression of the cauda.
Yeah, he calls it, we can decompress the corda like that.
Because if I take, Dr. Patil, if I take this cauda back, it will block the whatever foot plate is.
Just leave it there only.
Yeah.
Yeah, it may bother you for putting the Teflon or crimping it at the top.
Okay. Now give me the, this is, I think, enough exposure of the foot plate.
Yeah.
Can you see there?
Yeah, we
Yes.
can appreciate.
So I have to be at the important thing is to make a fenestra which should be almost perpendicular to the long process of incus, and it should be between the,
Madhuri, there's still
Yes, sir.
small bony prominence in lateral to the cauda. If you take away
Yes,
that,
I
your
know.
cauda may get more
Accurate.
mobilized also.
I know, but it can get cut also. Let
Yeah,
me try.
that because that can mobilize your cauda better. So you have to go a little deeper. You're superficial. You're too superficial.
First, I am separating for superficial drill down. Drill is.
अरे उनको बोलना देखो डायमंड बर भी देंगे ना 7 millimeter long use diamond bar if they don't have cutting bar.
The length of the burrs is going deep inside the handpiece.
So it may not be 7 millimeter bar length.
Length is less. Then a drill more accurate.
But see, sometimes your cauda, people talk about decompressing the cauda canal also.
Yes. I think part of the.
I think, sir, now it will go if I do much of more of this.
So for you're comfortable, do what you want. Don't listen to anybody.
Yeah.
As woman is supposed to be doing that. She doesn't listen to anybody most often.
Most often.
You do what you feel is comfortable.
Yeah,
I'll
just
make
be comfortable what you are right at now.
Okay. So now the footplate is nicely visible to me.
Fine.
मेरे को वो skeeter drill देना. I'll make a fenestra of 0.6 mm with a skeeter drill. कहाँ है
Right.
इसका? Okay. Yes.
What is the size of this bar?
0.6.
0.6.
Okay.
Very speed can be increased. Please. Okay. Give me more because it is not going through.
ठीक है
टूटती इतनी मेहनत के बाद टूटना नहीं चाहिए.
I got the skeeter spinner.
टूट गया.
Yeah.
Scissor दो.
Now it is sacrificed.
Now it is sacrificed.
माधुरी,
Yes, sir.
छुटकारा मिल गया.
हाँ?
छुटकारा मिल गया.
छुटकारा.
Whatever the mess was out. And this happens to all of us. This happens to all of us. Okay. It's not that it has happened to her. It happens to all of us.
देना एक वो sharp pick नहीं है आपके पास? And it is quite deep actually. दे दो इसी को बढ़ा दो 2000 तो कर ही दे.
Sorry, the centering keeps going.
She is an important
Microscope.
Yeah, focus.
थोड़ा और बढ़ा दे. हाँ. Yes.
Yeah.
I think the microscope is bothering her. The mobility of the microscope is limited.
No, and the focus also keeps, the position keeps shifting.
It is a very tough micro. Is this moving? Is this
Just
moving?
center it again, please.
Why is it?
Center it. Yeah, that's better. Off.
थोड़ा इधर करो सिर को ऐसे. सेंटरिंग है?
person who's holding the speculum now.
Yeah.
ऐसे रखो इसको सिर थोड़ा इस तरफ को रोटेट करो स्लाइटली
Not.
ओके
Your hairstyle is getting better and better. Sorry? Your hairstyle is getting better and better.
Yeah. Now. Can't see also. Ah, the bull is come.
Yeah.
so now now what I'll do is I can put reverse tapedotomy by putting the piston first and removing the suprastructure, or first we remove the suprastructure and then put the piston.
Do reverse.
Okay, scissor though. So we have both titanium as well as Teflon piston. Which one shall we
And
put?
Madhuri,
Hmm.
Madhuri,
Yes, sir.
once you're done a fenestra, have you changed your suction?
I am not going to, I'm just cutting the,
No, but once you make a fenestra, it's
Yes, sir.
ideal to change your suction cannula size, you
yes,
know?
sir. Yes,
So
sir.
that in case incidentally you're
I'll
around
take a
it.
very, very small, huh? Okay.
Also, do you
Smaller.
tend to cover it? Are you planning to cover it?
No.
4 point, they 4.5. No, I'm not touching. If I have to place, then I'll place only saline soaked gel form. You can give me one. So I shall not be using any additional drug in soaked.
You
this,
can use a
gel
dry
form.
gel form also to get a hemostasis better to.
Okay.
And see when she does suction, it will be much further than the fenestra. Suction cannula will be never close to the fenestra.
Right.
Yes,
I
that
think
is to be
that's very,
avoided.
very important.
Give me dry, sickle and dry. वो ये खोल दें ये वाला ये जो टेफलॉन
I think audience, anyone has any questions, please,
dry gel form.
you're free to ask.
इधर ही रख। Just keep it there.
Come here and ask the question. One wants to ask a question, please come here and ask.
They know it all.
Okay. अब वो दो मेरे को वो दो पिस्टन
Sonal, come and give some remarks. You do so many cases. Yes. Huh? Come. Come, Sonal.
उसको साइज डालेंगे ना साइज में पिस्टन को उसमें डाल दें होल्स बने हुए हैं उसमें हाँ टेफलॉन दे दो
Kishu ko bolenge. Sonal ko bolenge. There's so many cases. I want her to give some remarks.
देखो इसकी थिकनेस बेसिकली 0.5 होती है इसकी 0.4 होती है आप ये भी खोल दें टाइटेनियम भी दोनों एक बार खोलें 0.4 है
Hello, Madhuri.
हेलो हाँ सोनल
Gauri.
सोनल अच्छा गौरी हाँ
In which cases do you do drilling of the posterior crura?
Posterior crura is done when it is a straight stapes or obliterative stapes when it is not visualized directly. Then we do either partial crurotomy, posterior crurotomy or complete, and then create a space for making the fenestra. And many a times, even if we are unable to create a fenestra even after partial drilling of the posterior crura, then we can completely drill it out and take out the suprastructure of stapes and then do the fenestra making.
So you drill the crura only when it is obscuring the foot plate.
Yes. Or if it is, if I was not doing the reverse, उसमें डालें, हाँ, 4.5 वाले में डाल दें. If I am not doing the reverse stapes, then also before putting the piston, I will do the partial crurotomy to make it easy to break
Correct.
at the base. Huh? Then, so that's it.
To weaken the posterior crura, if it is
Absolutely.
very thick. Yes.
So nice. This we have put in 4.5. Okay. This microscope is, my arms are getting, this is something different. I have not worked. तो इसको ठीक कर दें हाँ इसको पकड़ो इसमें एक वो डाल देना नीडल टू वाइडन इट आई विल वाइडन इट
The position keeps changing all the time. Doesn't seem to be steady.
Okay, अभी यहाँ से adjust करो.
We can't see the piston.
we're just making the microscope workable.
Right.
It is giving trouble because
Yes, it's not centering
ये
and
वाला green कौन सा? Oh my God, इधर तो पीछे उसको पीछे करना है. This big elephant is. हाँ, अब ठीक है. टेबल थोड़ा ऊपर करेंगे.
I will just
ओके, ठीक है, थोड़ा और टेबल ऊपर. हाँ, टेबल ऊपर करो. यस. थोड़ा और ऊपर करो टेबल को. अच्छा, वो दे दो. अच्छा, give me a needle, straight needle. So this is the piston. We will widen it.
yes, we can see it.
No, needle, I mean instrument needle, straight needle. So we'll widen this loop.
One information about this length of piston. The Indian instrument dealers will send you the piston of, let's say, 5 millimeter. It may not be 5 millimeter. The worst is the jig, which they say 4.5 millimeter. It may not be 4.5 millimeter. These are very crude ones, you know. So when you're putting it, you have to be sure on the table that what you thought was 4.5 millimeter, because written on the packet, is it
Okay.
4.5 millimeter or not? You have to be very sure about it.
So it should be measured every time, right?
Yeah, the measuring, you can then directly say, like, see, you're the measurer. Some people can use a Teflon as a measurer. You put a 4-point Teflon piston on the foot plate and say a measure, and you know what is the length of it. So you don't need the instrument also.
Give me one more forceps.
The main problem here is the
Forceps. नहीं. Holding
sorry,
forceps.
centering is again not there.
करो तुम centering करो.
Bring it a little down, please.
Okay, I'll do that.
No, focus is not there.
I'll do that.
Yeah, okay, thanks.
I'll
Focus is
just
poor.
suction.
Could you explain once again, how do you measure the exact length of the piston?
Okay, I'll just do that. Just need to. Do we have another forceps there in the mind? Just a minute. Suction, please. Suction change करें. Suction change करना. अच्छा, block था. It is not working. Suction.
Okay. You can reduce the magnification a little and center it again, please.
Okay. Suction is bothering us. Centering तुम करो, बहुत जोर से हिलता है.
Little center, bus. Okay. Yeah.
You know? थोड़ा. Centering है?
Are you going to put the piston now?
Yes, ma'am. इसको थोड़ा नीचे करो section. Section को थोड़ा नीचे की तरफ. Yes.
Do you ever first do a remove the superstructure and then put a piston, or in every case you try and
No,
put the
ma'am.
piston first?
Both are okay. Both situations are okay. But yes, it gives a, liberty later on because we have fixed the footplate also and piston also, so we can easily remove the superstructure.
Right. Is there any time when it's not possible to do that?
Yes, I'll tell you. Air instruments nahi the.
Piston looks a little wider.
I think this is too big. 4.5, we put it in 4.5 only, no? It seems big by. Focus karo thoda.
Needs little focusing, ma'am.
The reverse tapedotomy, the space is a bit less. The limitations of reverse tapedotomy is that you get lesser space for putting the piston. Okay. Pick right angle मेरे उसपे instruments में है. You can give me pick, please. Pick is needed. हाँ, जब तक दो pick है उसमें. Hey, this is pick only. बंद है section.
It's in the hole now, just turn it. When you see it and you see experts doing it, then it looks so easy.
The Indian systems don't do it.
Right.
The good ones will start like it.
The Indian will close before it's supposed to close. See, it's closed already. It's already closed, that's why it's coming into the.
Close हो गया. Doesn't give you time basically, no?
Boy, exactly what I told you. Anyway, to manage to. बन जाए. It needs to be open. That's what I'm saying. It's going above it.
It needs to be opened again.
Yes, you're right.
Yes. Because as the time passes again, it goes back to its original place. Again, you give me a needle. I'll have to open it up again. That's why titanium piston doesn't give you that kind of a trouble. You put it there again. Fast. इसमें डालें. हाँ, इधर थोड़ा बड़ा है ना? Right. 4.5 है ना? Needle. Forceps. Fast वो फिर दोबारा हो जाएगा.
The important system stay better.
No, it's good to close up. It's good to close up. We have a memory. The Indians stop closing. The Indians never do. Yes.
Suction.
Don't want to close. Like what?
नीचे करो suction को. Suction नीचे लो कैसे?
There's a bad feedback. Not even the water problem.
Mhm.
Here the major of the lateral surface of the input. So very very even to the foot plate and then at the midpoint of the surface. Let us again at the midpoint. Okay. And then you add point in it.
अब दो pick देता हूँ.
If you start to use more often 4.5.
Uses?
We use there are picture. 4.5. But we don't measure. I have 4.5. I have 5.1, but मैं कभी 50 बोलेगा ना 2-3 बोलेगा.
Yeah.
Yes, they can 4.75 लगाया.
Now, can you, oh, better not disturb her. Okay. Can you center
now.
it now? Center.
Now I can center it, ma'am. So
Yeah,
I
this
just
is
want to
something.
repeat that action for the young ENT surgeons.
Yeah,
That when I was pushing it, the piston there with my suction, I was giving a counter
counter pressure on the other
support
side.
on the incus on the medial anterior side so that the incus does not get destabilized. Once
Correct.
the incus gets destabilized, it will be very difficult to do simple piston position. We will need to omit the incus and do a malleostapedopexy because
Right.
incus is very, very important for the this
So
assembly.
can you give some tips to them of to prevent dislocation?
So one
of the
thing
incus?
was, yes, one thing was I was holding the piston from its back, buttock of the piston at a 103 angle, 103 angle with the shaft of the piston. My forceps was making a angle of 103 degree between the shaft of the piston and my holding the piston. So I can show it with a different piston also.
Right.
That way, when you take it inside, you must be seeing the lower end of the piston and it should be made static on the whole fenestra and keep it aligned with the long process of incus in a parallel manner. It gets the support of long process of incus, it stays there. Then with the help of a suction and a pick, I will rotate it and the open face of the piston faces the long process of incus and then with the counter pressure on the incus by the suction and pushing from the shoulder of the pick, the piston on the handle of me, this is a long process of incus. Is
Right.
it okay, ma'am? Now I will remove the stapes suprastructure.
Yes.
Give me scissor. I'll cut the
Tendon.
stapedial tendon. Though I can drill away the. Give me drill. This bone. Curate de do. Acha, acha. Now that chorda is gone. Okay. Now can you see?
Yeah, where's the quarter? That go where? Huh? She got it.
Okay. Let me cut the this stapedial tendon close to the head of the stapes.
There's no point putting the two ends of the quarter back. They don't usually join up. Patients complain quite often.
ऊपर कहाँ? अब मेरे को वो दो drill. I will just do the posterior corotomy and then remove the suprastructure. ना skeeter drill. बस सतीश 2 मिनट आपका केस फिर से. हाँ जी, हाँ जी. Now I am doing the posterior corotomy. Focus करो. Okay. So this I have done the posterior corotomy.
Right. How close to the base do you do it?
Closest possible. Because we don't want to leave the posterior crura behind, which can, restrict the movement of the piston, up and down movement of the piston. अब मेरे को incus. I will separate the incudostapedial joint and then remove the suprastructure.
So you remove it as low as possible,
Yes, closest to the base, ma'am.
closer to the base. And anterior?
Anterior, I will just put because that is quite thin.
So you can do it at any time, any
Putting
time.
just a small pressure down. Centering है.
It's moving a lot.
This microscope is slightly.
Yeah.
Again, I have to give support to the incus while separating the.
Incudostapedial joint.
Yes, ma'am.
Okay, fine.
Suction बंद हो गया. Light crimping I'll do. First I remove this.
You put gel foam around it?
Never put a gel foam around the insertion because ma'am, it will not let the oval window membrane formation, which is important for sealing the fenestra. मेरा लंबा वाला forceps होगा.
No, what would you advise them? That
Just
around
put slight blood clot around. So a
yeah.
small blood drops there to seal the slight space around, because the oval window membrane and ostial membrane, you know, it has to heal around the fenestra. If we are putting any gel foam there, it will not let the heal, because once we make a fenestra, in 24 hours, polymorphs start assimilating there, followed by the fibroblast. Then fibrocytic, this membrane forms in 1 week. And the whole thick fibrous membrane forms in 3 weeks.
So you should just make sure that you do not put gel foam in the middle here
Gel foam, yes.
in these cases, right?
Yes, yes.
Otherwise, you just hold it till the oozing stops. Suppose there is oozing.
Yes, yes, ma'am.
Okay. What is the diameter of the shaft?
It was 0.4, ma'am.
Beg your pardon?
0.4.
0.4.
And this fenestra was 0.6. So it is very marginal gap, which is usually filled within a day or two. Forceps.
Madhuri,
Yes, sir.
somebody has a question that you put up Teflon and you can see bit of fenestra around your Teflon. Would you ever think of putting any soft tissue there?
No, never, sir. I don't do that. I just put the blood clot, blood.
Yeah.
Don't move.
The House here Institute, they used to collect the blood from the vein and keep it ready. They won't use this blood, you know. I don't know what was different. And they'll fill the whole middle ear with the blood clot. You see? Yeah.
So I have performed the crimping also. Let us see the movement round window if it is
As far
possible.
as this is concerned, suppose I make normally I make 0.6 and 0.5. But if my fenestra is a little bigger, then I like to put small tissue. And that small tissue has to be small tissue. What you're trying to block? 0.1 millimeter, no? Or 0.1, 0.5 millimeter. Tissue should be so blocked.
Hello, sir.
Yeah.
Hello.
Yeah.
Sir, Dr. Satish is standing here. He is also believes it that the blood should be there to fill the gap.
Yeah.
Because it will act like a glue only and it will not restrict this pick.
I mentioned it that this is what House here Institute used to do. They used to
Hello,
put
sir.
Ah.
Sir, blood in the vestibule is detrimental, but you know, once you make the fenestra, we are never supposed to suck over the fenestra and keep the vestibule blood fluid filled.
Yes.
pressure inside the vestibule is always more than the pressure inside the middle ear. Now,
So the
if you
blood is
pour
not
the
going to
blood
go
on the
in.
foot plate, if you pour the blood on the foot plate, it is never going to trickle inside.
Yes.
And it is definitely one of the best way to seal the fenestra. As long as
Okay.
piston length is adequate, it is not over long.
Okay.
If
Now,
pist-
Madhuri, you had anything to say? We don't want to say any more, sir. In the sense, now you know what you are going to reflect the canal skin and a TM flap and put the gel form. They had some function to do for 2 minutes. Let them finish it. Okay. Put off the Madhuri, you have anything last remark to say?
Thank you very much, sir, for the patient watching.
Yeah, thank
Thank
you
you.
very much. Thank you very much for tolerating that microscope.
Thank you, sir. Thank you.
Before moving on to sir's lecture, on behalf of Department of ENT, BDBA Hospital, sir, we would like to present you with a small token of love and appreciation. Can I please have the entire BDBA department on stage? Sir,
A lot of males think of love as a one thing only, huh?
Hello.
thank you, sir.
In my courses, I'll always say that temporal bone for autologists is your Minara, Masjid, Temple, Gurdwara. Temporal bone, you have to respect tremendously. When you're doing a dissection of temporal bone, you think you are operating VVIP patient. Go so cautiously, so carefully, and I'm just going to show you for a 2 minutes. I told them this gold, pure gold. अच्छा gold plated होगा. Gold का होगा तो मैं अभी जाके बेच के आता हूँ. Anyway, this is a gold plated temporal bone, and as I said, I respect the temporal bone, and I want every autologist to respect the temporal bone. This is here you are going to become a good autologist if you go on dissecting temporal bone. Thank you very much. I'm going to show you a very interesting case done on this Tuesday by my colleague, of course, my patient, Dr. Amul. Now, this is a case of stapedectomy. We were planning to do a stapedectomy. And this, if you see, this is a Day1 facial now. I'm going to play, you'll be able to visualize, and it's touching the crura. Now, what happens once you have a Day1 facial now, and it touches the crura, moment you remove the superstructure, there's a likelihood that it can descend down. Let's play the video. Let's play the video. From where I play the video? So this is a facial now. Facial now, you're not going to touch any sharp instrument. We are taking a ball prop. This is done on this Tuesday. And he was trying to cut the tendon. I said, before cutting the tendon, you show them a Day1 facial now. Okay. Now, we thought he'll be drilling the posterior crura. Why this picture is coming? ये नीचे picture क्यों आ रहा है? ए अमूल खाली picture का आए थे? Okay, so you can hardly see any foot plate so far, and we are drilling the. It's coming in the base sometimes. So the posterior crura with a skitter burr of 0.5 millimeter diamond burr was being drilled out. And this stage, you can see fraction of millimeter foot plate inferiorly, okay? So what we are doing, we are trying to drill at the annular part, or let's say margin of the promontory in connection with the stapes. And we hope that after removing the suprastructure of the stapes, we should be able to see the foot plate better. Because of facial now, he's taking more, he's struggling to take out this piece. Okay. Now you can see the foot plate better. Of course, we have to still remove the suprastructure stapes which is hanging around there. And now you can see the foot plate much better. This is about 1 millimeter. So we thought we'll decongest the facial now. We put a gel form, soaked in adrenaline, and we kept it for some time. Even if 0.1 or 2 millimeter space we get better, you will be more, see the shaft of the perforator may be 0.5 mm or 0.6 mm or 0.4. Shaft is bigger. We didn't want the shaft to touch the facial now as far as possible. There's still some tissue hanging around there. And now you feel that you are seeing less foot plate than you saw before. This is 0.5 millimeter perforator. Now you can see better. You think this is good enough? 0.6 millimeter Teflon, 0.6 millimeter fenestra, and then the Teflon inside. A lot of people have misconcept that if the Teflon touches the facial nerve, or if you're doing ossicoplasty or the cartilage A, B, C, D, it touches the facial nerve, patient has chance of getting facial nerve palsy. That's a misconcept. Okay, there's a total. If you're not damaged the sheet, you are not going to have any problem. But in this situation, we still told the anesthetist, give a shot of steroid. Okay, because you have touched the facial nerve, you're not what you call handled or mishandled the facial nerve, and this patient immediately post-op. And half an hour, then I hanged around. Normally, I had to walk out of OT and ho gaya kaam, you know. So I hanged around for more than half an hour to see her facial nerve function was good. And same day evening I saw her, next day morning I saw her facial nerve function was perfect. So important thing is, these are the rare situations, you know. And I'll give you two more incidents. Many years back, Madhuri rang me up that I cannot see foot plate at all, because the facial nerve is overhanging and covering the foot plate. Then you can do a fenestra on the promontory also, just as close to the inferior margin of the what you call foot plate. And you can use some Teflon, may not be possible because the angle becomes difficult. You can use metal clips. And once Rahul had rung me up a few years before that he had same problem and he could not put the Teflon. He put the Teflon, but he was insecure whether he's going to stay there. So he used the cartilage. And because his fenestra was a little bigger, and so he used the vein graft over that fenestra, and then he used the cartilage splitting around, you know, split it and going around the incus. Okay, so this may not give perfect result, like airborne occlusion may not become 0, but if it airborne gap comes from 60 dB to about 20 dB, that's good enough. So these are rare conditions, and in case if you do not have expertise, please give up. Don't damage the facial nerve. The facial nerve damage gives equal trauma to surgeon and the patient. And since the patient has a medical legal, you know, somebody, chacha kaka mama se badmash hai, he can make your life very, very miserable. So give up in certain situation which is beyond your control. I think we can start the other case. Anybody has any suggestion, question? Okay, this was done on this Tuesday. There was Stepis case. I thought better show. And more than I want to show you my registrar. Get up, idiot. My every registrar is a good Stepis surgeon. I tell you the story. There's a one boy who was my registrar. He went and practiced Delhi, Rajiv Bhatia. He's the tallest scientist in India. When he was trying to do stapes in Delhi, in that era, Delhi stapedectomy was done by only Santosh Kakkar. Nobody did stapedectomy. But in Bombay, we trained every registrar to do stapes if they are good enough. Most of the registrars are good enough. Some people come and do work for you 3 months or something like that. When did you do stapes, Narayan? Which year? There are boys from Chandrakaran. When did you do stapes? He did as a registrar. There's a Ravi. You know, this Ravi is from South India. He's from Bangalore. I used to abuse him in Hindi. After 3 months, somebody told me he doesn't understand Hindi abuses. I really blast people, you know, in the sense, when you blast people, when you care for them, when you tend to correct them, when you care for them. Where's Sonal? She's gone? Sonal has to go and teach her in a clinic, in a private clinic. If she did mistake, I have to pull her hair. उसके बाप के आंख से आंसू आता था, उसने कभी बच्ची को हाथ ही नहीं लगाया था, you know. So I can be very, very good to my student, and I can be very harsh also. My language is harsh, everybody knows about it. So important thing is every register of mine, I'm proud to say are capable of doing stapedectomy. It may happen, Mapankar when he did first stapedectomy, sir, can you come and stand by? Okay. Deepak Desai when he did first stapedectomy, sir, can you come and stand by? I stand by. I don't do the surgery. I'll tell you incident I just told Pete. One ENT surgeon for 20 years depended on particular ENT surgeon to come and do stapedectomy for 20 years. I went to him 3 times. He didn't have to call anybody. This is a difference. This is a difference. It's such a proud privilege to see that your boys can do well. Okay. So today, Narayan is a skull-based surgeon. Satish is a skull-based. Satish and Narayan had done my private acoustic neuroma of first-class patient, my glomus themselves. He used to do laryngectomy. First 2 laryngectomy, I'll be in the theater. Third laryngectomy, I won't be in the theater also. Because if I stand there, he's using artery forceps somewhere where I might like to use a cautery, for example. I would like to use a scissor. So you tend to impose your ideas unnecessarily. What you can do with cautery, you can do with artery forceps, you can do with a scissor. So after you develop faith in them, so give them a self-dignity, self-respect. Rahul Agarwal, once he did a facial node decompression, and 2 people, Mohan, who is a very famous now for the endoscopic sinus surgery, you know, when we were going to Baryosana, the day before they came for visa, 2 senior people said, are you doing any interesting case? I said, yes, I'm doing one facial node decompression. They came and saw this facial node decompression, which was done by my registrar, Rahul. They asked me how senior it is. He has not done even DNB. You see? So this is the important thing. You train them, and you cannot make everybody a good surgeon. गधे को अपन घोड़ा नहीं बना सकते, घोड़े को अपन रेस हॉर्स बना सकते हैं. Okay, so this is a message for teachers, please. And when I said Patil, there's so many stapedectomy. How many ENT surgeon he operates for? 15, 20? इतना ENT surgeon के लिए surgery करता है. He operates for 15, 20 ENT surgeon ear surgery for last. He's been practicing from 1990 roughly, 88. Since then, he's been going every day, he's going and operating for that. How many people call you for surgery, Dr. Narayan? How many people call Amul for surgery? How many people call Dev for surgery? Dev has been called for surgery by people who are much, much senior than him. So, teachers, please be proud to bring your students up. Okay.
I would like to felicitate moderators for the session, Dr. Pilu Hakim ma'am and Dr. Sanjeev Pethe, sir, by Dr. Rajesh.
इधर आवाज क्यों नहीं आती है?
All that you have done. Huh?
Say it again, but they didn't.
I said that I am proudest of Dr. Morwani because he is now become the teacher of teachers. And all those whom he has taught now teach others. And I think, as he said, I think that is the greatest satisfaction we can have. Thank you.
Once somebody, Haryana State Conference gave me award of teachers. And people from AIMS and PGI were very upset. Then I taught them few things. They were all right.
Hello.
I would now like to invite the next moderators, Dr. Hetal Marfatia ma'am. Hetal ma'am. And Dr. Narayan Jaishankar sir for the next case, which is inverted papilloma. The patient has already been induced. Yes, sir. Yes, sir. The next patient is a 72-year-old male who complains of epistaxis from right side, which is spontaneous, mild, and this is there since 4 months, along with right-sided nasal obstruction, which is intermittent. On examination, there was polypoidal mass in the right nasal cavity and the air blast was decreased on the right side. On contrast enhanced CT scan, there was moderate pansinusitis with complete obliteration of paranasal sinuses. Recesses, ostia, and soft tissue mucosal opacification containing dense, inspissated, minimally enhancing contents without any osseous remodeling, resulting in coalescent thickening of nasal turbinate. On the MRI, there was an enhancing polypoidal heterogeneous soft tissue lesion involving the right maxillary sinus extending into the right nasal cavity and posterior choana, causing expansion of the right OMU. On a nasal biopsy, the HPI suggested of inverted papilloma. We'll take you to the OT for the further discussion of the scans and about the case. Thank you.
Hello.
Yeah, Satish, go on. We are with you.
Hi, Narayan.
Hi, go on, Satish.
So, as you have known about the case, the patient with some polypoidal mass and a CT scan, there's a plain CT scan was done. See, what do you see on plain CT scan? A simple sinusitis. Without a contrast, you can't make out whether it is a tumor or a plain sinusitis, as simple as that. So this CT scan doesn't give much information, and if you have a printout, it can be as good as useless. Now, let me tell you where the mass lesion is and what do we need to get information, what we expect from the imaging. For inverted papilloma, this is a very interesting pathology because many times they are diagnosed as a surprise finding while you are operating for sinus surgery, as you may get a polyposis or something like else, and then you discover a papilloma behind. And many times you have to cut a sorry figure because of a misdiagnosis. So a good CT scan, and if you read on this dynamic on the DICOM format, you can still pick up. Let me tell you, on this plain CT scan, how we had a doubt of, the inverted papilloma we can think of. See now what I am doing. See carefully, I am changing the window setting. I am changing the window setting on the DICOM. Can you see some change?
Yes, Satish.
Here is the mass lesion, it looks like enhancing. It's a non-contrast CT scan. And see the background, which was the sinusitis appearing as a dark with hardly any signal on this particular window setting. So this can differentiate simply the tumor from the sinusitis. Can you see?
Yeah, we can see that.
See, here is the tumor and all the sinusitis component is suppressed even on the plain CT scan, giving you a something idea wherein you have a biopsy in hand of inverted papilloma. So from imaging, we need basically 3 things in inverted papilloma to know. One is to confirm the diagnosis if you don't have a histopath. Number 2, site of attachment. This is very, very important for 2 reasons. One is to plan a surgical approach. This is very, very important to know the site of lesion to plan a surgical approach. Suppose the papilloma is attached to somewhere laterally where you can't go endoscopically through the nose only, you may have to expand your approach, you may have to do dankers, you may have to do like in the frontal if it is attached to, you may have to do a draft. If it is attached to the skull base, you may have to do some expanded approach. So site of attachment is very important. One important thing about the papilloma is like angiofibroma or any other benign tumor. This is a benign tumor and it has a cure if it is completely removed. As simple as that. It has to be completely removed to give patient a cure. Now, what are the difficulties? Difficulty number one, this tumor involves the aversion system of the underlying bone and enters the bony canals, enters the bone. If you remove the superficial part and leave even a small sliver of the tumor inside the bone, it is going to come back. It is bound to come back. That is difficulty number one. So, we need to know from imaging where exactly it is attached to so that we can remove the underlying bone completely. If you remove the bone completely along with the tumor, the site of attachment, you can give a cure. So, the number one difficulty is to remove from the underlying bone for complete removal. Number two, it may change into malignancy. It may transform into malignancy in small percentage of cases. In long-standing elderly patient, maybe in up to 10 to 15%. And you never know before. The difficulty again in identifying malignancies or surface biopsy may not reveal a malignancy, even if it is malignancy going on in the depth. Because malignancy starts in the depth, malignancy starts at the site of attachment. Even if you have a confirmed diagnosis of papilloma from surface biopsy, it doesn't rule out an inside malignancy. So that is a big challenge because again, a post-op report of a patient operated on a biopsy of benign papilloma and post-op turns out to be a malignancy again is a big challenge. Because then for malignancy, you need a bigger approach with good margins and a complete excision, wide excision with margins. So the biggest challenge, yes.
Can I add one small point because there was a query over here. These patients, when sometimes, we have all had patients of taken up as antroconal polyps and then comes back to us and say we have not been able to remove, there was too much of bleeding. So what I would advise all these juniors is always do an MRI scan for all these patients whom you think are pure antroconal polyps. Like you said, antroconal polyps or whether it be sinusitis or the maxilla or whatever. And MRI is the most differentiating. I think you would also agree with that. And typically the CCP pattern, which even you talk about, I think you should lay some stress on that and how MRI is very necessary in the pre-op, planning for this patient.
Yes. So MRI is key for many reasons. Number one, to substantiate your diagnosis on the clinical suspicion in spite of not having a confirmed report of papilloma by means of its classical cerebriform convolution pattern, because this tumor has a tendency, as the name implies, it starts from the depth and goes back in the stroma inverted. So in inverted, you see the tumor as well as hyperplastic epithelium, inflamed epithelium as a cerebriform pattern. So the MRI is required for diagnosis, number one. Number two, if any hidden malignancy which might have started in the depth of the tumor, which even the surface biopsy might have missed. That is such a difficult thing to know. Your surface biopsy, like in this patient, reveals inverted papilloma, but you never know in the depth whether it has transformed into malignancy or not. So MRI can pick up that by means of seeing the loss of cerebriform pattern. Third is the site of attachment, where the CCP starting is the site of attachment. Now, quickly, what we get on CT scan in this patient? See, this was the plain CT scan with looking like bilateral sinusitis. You can't differentiate where the tumor is. I'm changing the window setting and suddenly, see now, you will see the sinusitis pattern disappearing, appearing absolutely dark on this setting. Can you see the sinusitis has gone dark? And this is the tumor which is attached to the lateral wall of the nose. This tumor is attached to the lateral wall of the nose, and as we go behind, looks like attached to the posterolateral wall as well. Now, coming to the investigation, like Narayan mentioned, MRI. MRI is certainly game-changing. In this particular patient, MRI is game-changing. Now, what do we get on MRI? See this. For a tumor, the MRI will enhance on contrast administration. See, this is the tumor, and this is how the MRI of this patient is, where the tumor is enhancing And can you see the cerebriform pattern? Can you see the cerebriform pattern in this tumor? Which you will otherwise not see in any other malignant or benign tumor. See this cerebriform pattern is because of, see these alternate bands. Can you see? In a good quality MRI, you will see much better. See these kinds of cerebriform pattern, this alternating hypo and hyper intense band. Hyper intense band on contrast is the tumor and hypo intense is the inflammation. On contrary, if you have a T2 weighted image together, see this T2 weighted imaging together, see this hypo and hyper intense band on T2 weighted, can you see?
Yeah, we can all see that quite clearly.
Can you see the CCPs? It itself confirms the diagnosis of a inverted papilloma if you have this kind of a pattern. And see, that shows the site of attachment. It looks like this is attached to the somewhere on the lateral wall, inferior to the orbit. See, this is the inferior medial angle of the orbit. And this looks like attached to the inferior medial angle of the orbit. And see, as I go behind. Now, another thing, what you can make out on MRI, very clear. See on T2 weighted, this is bright, this is fluid. Can you see? See, laterally everywhere is fluid. So tumor is not there. Tumor is hypodense on T2 weighted and the fluid is hyperintense. So this tumor is not attached anywhere far laterally. It is attached onto the lateral wall here, maybe on the turbinate and to the inferior wall, medial wall of the orbit and the posterior lateral or posterior medial wall of the maxillary sinus. So this is overall the site of attachment according to the MRI. So first of all, CCP establishes the diagnosis. Number two, the pattern can tell you where this tumor could be attached to. And third is any possibility of malignant transformation. See, in this pattern, you can see alternate bands. Had there been complete loss of everything with a central necrotic area, you would see loss of CCP, and that gives you a fairly good idea of a possible malignancy going on inside. This is so important. Otherwise, your surface biopsy may tell a benign papilloma and it turns out to be a malignancy in the inside. And again, it is a big surprise. And you need to tell your patient later on that you need one more surgery, which is a bigger surgery than the previous one, to get a complete removal with margins. So MRI can definitely avoid that situation of a second surgery. If you on MRI, if you find loss of CCP with suspicion of malignancy, you can prepare your patient accordingly in the same stage by means of a frozen section to confirm malignancy and then go ahead with the same stage with a complete radical surgery. So you can definitely avoid a second stage surgery if you have a good MRI along with. Third is planning your surgical approach. Now, if you have a tumor in the nasal cavity, you can go straight endonasal. In this patient, my tumor is going, involving the lateral wall, going beyond the lateral wall, though it is not going far laterally into any of the recess, but it is here attached to the posterior lateral and posterior medial wall. Posterior wall, inferior wall of the orbit, and the medial wall of the lateral nasal wall. This area is attached to, as I said, to this tumor. There is a complete cure if we remove completely. Remove completely means the underlying bone as well. If I remove this underlying bone completely, I can give this patient a cure. So in order to drill away this bone completely, I need to have a good exposure. And that's why in this patient, we'll most likely take a Denker's approach, modified Denker's approach, to go head on to that area which has bony, involvement by the tumor and which requires or need to be drilled. So the surgical approach planning is very, very important based on the radiology. See, this is tumor. And we are operating from here, so I need a good exposure and I'll do a modified Denker's over here to get a head-on access to the tumor, and we can drill away the underlying bone completely to give patient a cure. So planning a surgical approach is very important. Fourth is prognosticating such patients. In spite of a benign tumor, which has a tendency of recurrence if it is left behind, we divide into a favorable and non-favorable category. The reason being, favorable category is where it is possible for you to completely radically remove the underlying bone. Like in this case, if the tumor is attached to the turbinate, I can remove the turbinate radically. If tumor is attached to the lateral wall of the nose, I can remove radically without any issue. If the tumor is attached to the inferior wall of the orbit, we can remove the inferior wall of the orbit, keeping the periorbita intact. If the tumor is attached to the posterior lateral wall of the maxilla, we can still remove it completely with keeping the pterygopalatine fossa periosteum intact. There is nothing is stopping us for a complete radical bone removal. Now, what is unfavorable? If the tumor is attached somewhere to the skull base, where you may not be, or it may not be possible for you to go radical. If the tumor is attached to the walls of the sphenoid sinus, last demonstration we did a patient was 7 times remover who had a multiple attachment in the sphenoid sinus, and we had to drill away from the carotid artery and optic nerve and everywhere. But that is not so easy. That is considered unfavorable. There are chances of complications are more. So those are unfavorable tumors. If the tumor is attached somewhere into the frontal sinus, those are unfavorable because you need to drill out the frontal to get head-on access to that. You may need draft, modified, Lothrops and all those approaches. And still, if the tumor is attached to the anterior wall, you may have to resort to open approach. So those are unfavorable situations. So this to me is a favorable tumor. I can radically remove the walls wherever it is attached to. Radically means completely removing the walls as a whole. So to me, this is the papilloma, where is, in my opinion, is a favorable tumor where we can radically remove the underlying bone. That our crux of preventing recurrence is complete removal of the underlying bone. That's it. So these are the few things you need to keep in mind while looking at the scan: the diagnosis, possibility of malignant transformation, site of attachment, and favorability criteria, whether you can remove it completely as a whole or not. Anything, Narayan?
Yeah, I think you have said it fantastically. So one thing which I teach my students is that whenever you have a single sinus involved, even if you're sure what it is clinically, or you have a suspicion on CT scan, I nowadays do more of MRIs, which at least tells me whether it is fungal sinusitis versus antroconal polyp versus inverted papilloma. And so the use of MRI has increased, whether it be any limited sinus or one side involvement.
Yeah. Yes, definitely. Now see, Narayan, one more sequence I have placed, that is diffusion weighted imaging. This to me is one of my most favorite imaging protocol for many reasons, particularly for tumors. Diffusion weighted is a bioimaging. Bioimaging means, since MRI is a magnet, it creates a magnetic field. And what MRI in this imaging finds is the motion of water molecules in the magnetic field. Now, in tumors which are benign, there is more water content, more water molecular movement, less diffusion restriction. In malignant tumors, more diffusion restriction. In less differentiated, poorly differentiated malignant tumors or lymphoma, most severe diffusion restriction, as the nuclear cytoplasmic ratio is more, hardly any water content. And now see here, this tumor, it is so bright, there is hardly any restriction in the diffusion. I can say very well, quite confidently, that it is a benign one. There is no possibility of malignant transformation in this tumor, as my diffusion is not showing any kind of restriction. Had there been diffusion restriction, I would definitely think of being a malignant lesion and accordingly plan or surgical approach and counsel the patient to take a deeper biopsy, multiple biopsies, deeper down until you get a complete diagnosis, that too on a frozen section, so that you can take a call intraoperatively at the same stage. So that is another very, very important, sequence, and that you have to order to your radiologist, otherwise they will not do. So the diagnosis is clear. The area of involvement is clear. It is a favorable one. The planning is clear. We are going to do a Dankers, and it looks very clear that it is not malignant. So let's see how we can remove it completely from the underlying bone to give this patient a cure. So in a couple of minutes, we'll be ready. Narayan, you can continue discussion any point of time.
Yesterday there was discussion. You saw the CT scan of this patient. The maxillary ostium was opened widely on opposite side also. What is that? How do you explain that? So it was open on maxillary ostium. The tumor is on the right side. Okay. On left side also, CT scan dekhega na, the ostium was so widely open. It looked probably the patient had probably surgery before, probably. And then it is MRI, we talk about CT scan. First cut. No, but he is widening of the osteum means तू जितना क्या उससे जास्ती बढ़ाता है. You know what I mean? It's a big word opening. Auditorium, sorry, theater. Can somebody show us the first CT scan of this patient which Satish Jain discussed with us? Somebody in operation theater, can you please show us the CT scan, first CT scan which Satish Jain discussed? They are listening to us, they'll do it.
Yeah, so again, a small point which we want to make to the people listening is, suppose on the MRI, I usually go back to the MRI department, speak to my the radiology team and, discuss the pathology. Suppose the radiologist feels, now this is a simple inverted papilloma. Suppose they feel it's some sort of malignancy. Don't rush in for surgery. Always take a biopsy, determine what it is, and then plan your surgery accordingly, because everything may not be completely surgery. So determine your pathology before you rush it for surgery, especially when it is malignancies. For benign lesions, you're going to excise it completely. Ethel, you want to say anything?
And also the histopathology will decide whether it is amenable to endoscopy, or you will require open surgery, or you require CTRT, or whether you really need to do endoscopic excision.
So I'll ask Hetal a question. Hetal, if you have a inverted papilloma from the frontal sinus, what is your post-op management? Say you have removed the whole lesion. How will you, check the post-operative course of this patient, or say the prognosis over a couple of years?
If the inverted papilloma has gone to only frontonasal recess, then I know that, you are quite okay. But if it has gone into the frontal sinus per se, it all depends upon how have you delivered it. Basically, if it was just a tentacle going up, then the treatment remains different. If it was adherent to frontonasal recess, then you really need to do the drilling, and it will have the same prognosis, but you need to very closely follow it up. And it is said that the tumor which are attached to frontonasal recess are more aggressive. They've got more chances of getting into transitional cell carcinoma. So any which way, all inverted papilloma, we have a follow-up 1 month, 3 months, 6 months, 1 year, every year. And then you should follow it up with following imaging. You have to do externals and drill out that external frontoethmoidectomy.
Hello. Hello.
Yeah, Satish.
Yes, Narayan.
Yeah, Satish.
Are you? Yes.
We have your picture. You can keep talking. We were talking of, since you were not washed up, we were talking of protocols for managing residual lesions or follow-up for these lesions of inverted papilloma. We were talking of that. But if you're ready, we are ready to go on.
Yeah.
Or if you want to talk on follow-up protocol, you should let us know. Imaging and what you do for residual inverted papillomas.
So now,
you need to speak louder. I think your voice is gone now.
For the papilloma have changed in couple of decades to endoscopic approach with certain advantages. Like I mentioned,
speak louder. We can't hear you clearly.
Hello,
Satish.
Yeah.
Take your mask out and
volume बढ़ा दो.
Need to speak louder.
Yeah. Can you hear me better now?
Yes, we can hear you very much.
Okay. So Narayan, endoscopy has certain advantages in terms of complete removal which this benign tumor requires for the cure. You can go under direct magnification, illumination, directly to the site of attachment, and you can drill away that to give patient a cure. With this endoscopy, now the follow-up protocol is also changed. You rarely need an, imaging unless there is an obvious tumor infiltrating the surrounding. With endoscopic follow-up, you rarely need any imaging, number one. Number two, you can follow these patients with a marker also, which we do. And there are so many studies done on that. Serum squamous cell carcinoma antigen type 2 is a great marker, which is elevated in inverted papillomas. The name implies the squamous cell carcinoma antigen, but it is significantly elevated in papillomas. So pre-operatively, you can get the test done. The moment you remove the tumor, get the test done. After 3 days, it will come back to normal if you're completely removed. And you can follow with that marker every 6 monthly for 2 or 3 years. Even the slightest rise or trend of rise will tell you that somewhere the recurrence is going on. Number one, even before the clinical recurrence comes, the clinical manifestation will come when the recurrence level is, the magnitude of the recurrence is massive. And that too, you don't need imaging. If you have a endoscopic access, you have an endoscopic surgery done. See now what I'm doing, I'm just debriding the luminal component. Just the luminal component. As I mentioned earlier, even if the malignancy, this has transformed into malignancy somewhere in the depth, the superficial biopsies may not reveal. And malignancies, unfortunately, starts in the depth, not on the superficial component. So this is always a surprise if you don't have a good MRI to get the diagnosis of malignancy post-operatively on the post-operative specimen. That's why a good MRI can certainly avoid a second surgery by means of a strong suspicion before the first surgery on MRI of malignancy. So the MRI is game changing, I tell you, in this particular surgery. Now, this is the free component. See, the luminal component has been debrided. This is just secretion, nothing else. See, that's the luminal component. And see this tumor. Why endoscopy is so important, why it is an edge over the open approach? Because you clearly see at every point of time where the tumor is attached to. But it is not the luminal component which is important. The important is the site of attachment. Now see where this tumor was coming out of, like AC polyp, always from the accessory ostia. Can you see the accessory ostia behind?
Yeah, very clearly.
So it is always comes out of the accessory ostia if it is coming out of the maxillary sinus. See, this is accessory ostia. And this is the uncinate process anteriorly, which I have not removed yet. It is still intact. No, the denker will be dictated by the site of attachment. We have already planned, and the tumor might be attached somewhere laterally inside the maxillary wall, posterolateral wall. And we need really a good head-on access to drill away completely the underlying bone to give patient a cure. If you leave even the slightest residue in the underlying bone somewhere, it is bound to come back. And then in the recurrent cases only, the chances of malignancies are high, particularly those patients who are smokers. Elderly, smoker are the high-risk factors. Now, let me remove the uncinate. Give me the backbiter like a regular sinus surgery. That's the turbinate. We have seen on the scan, our area of interest is limited to the maxillary sinus and nowhere else. So, just I am lateralizing the turbinate this way, in the simplest way. That is the tumor below. Give me the reverse biting. I hope the picture is good there.
Very good, very clear.
See now, I have taken the reverse biting. And see the lesion where it is attached to inside the maxillary sinus. Let me open up the maxillary. Yes. 40 देता ना मिक्सर में तो करता है तो. See, this is all secretions. That's the remnant of the uncinate where the tumor was attached to.
Yeah.
That was the area where the tumor was attached to. The uncinate. Wash. Give me a wash. Give wash. Give me a wash. घर बना. See where this tumor is attached to. That's a part of the uncinate. And see, still the tumor is lying below. That could be attached to the inferior turbinate as well. We should be able to clearly see the complete attachment of the tumor. If you can't see, rather than compromising the visualization, better to do an expanded approach. And here, we'll not think twice before doing a Dankers to get head-on access. I want to see complete surrounding, not only attachment, but the complete surrounding where the tumor is attached to. Let's see further and then we'll convert to the Dankers in case required. See the tumor there?
Yeah, we can see it.
See
You are already seeing the attachment.
see the maxilla behind, which is normal, laterally normal. It is attached somewhere here only. See this?
So most classical attachments are at the Schneiderian membrane. Developmentally, Schneiderian membrane is
Okay,
at the
okay.
junction of maxilla and nasal cavity. It's the transitional epithelium, which is the one where the attachment occurs.
See this? See this component which is hanging in the
Maxilla.
See the maxillary sinus. Can you see?
Yes.
It was all occupying the maxillary sinus, but not attached anywhere laterally. Could you see very clear or not?
Yeah.
I pulled out to see the maxillary sinus is very nicely spared. Can you see very clear?
Yes. So that is the point of attachment.
There is no point in sacrificing
Satish,
unnecessarily structure. Yes.
Satish, when you were reading the MRI, the thought did occur to me it was attached to the medial wall rather than the inferior orbital wall, as you were saying. So that's why.
Yeah, it is here. See this. See, it is here. Can you see the tumor there?
Yeah.
See the inferior orbital wall where the tumor is attached to.
Showed that, but there was also a place where your CCPs were arising from the medial wall of the maxilla.
Yeah, so this tumor was occupying there.
Correct.
So I pulled it out and see where it is attached to. It is attached to the lateral wall of the nose here. See this attachment.
Yes. So what is your further plan? What is your further plan? That's what I'm saying.
So far, let me remove this luminal component again, because now I have got to know the site of attachment here.
So will you send
Now I have two sites of attachment, one over here, one over there. Can you see?
Yeah. Satish, will you send this component for histopathology? This is more representative than the
this one that doesn't look like malignancy
not
for
this,
that matter.
the one which you just removed.
Yeah, the attachment site.
Yeah.
Attachment, both the attachments I'll send for histopath. It is the site of attachment where the malignancy starts, not the luminal one. Those are most representative. You may get a negative report on the surface, yet having malignancy in the depth, and that is irony, and that is where the MRI can save you. Look out there. So far, a lot of things have been clear now.
Yeah.
Let me show you with the 70 degree, the exact area of interest. Okay.
We can actually see it.
Our lumen is very clear. Nasal cavity is very clear. One site of attachment here, one here. And now we will assess how can we remove it thoroughly. Give me 70. Let's go inside the 70. The inside is clear. And there is no point in sacrificing those, normal areas. Yes, I will do that. See now, the rest of the maxillary sinus is pretty clear with just, boggy mucosa because of the sinus obstruction. Can you see?
Yeah, we see.
Now, this is my first area of attachment, interesting area of attachment above. That is the floor of the orbit I told you from MRI. See that?
Yeah.
Okay. And this is the second area of attachment to the lateral wall of the nose. See there?
Yeah.
But there is nothing inside the maxillary sinus for that matter. Maxillary sinus from inside is ultra clear. You can see very clear.
Yes.
Now give me the debrider and keep the coagulator ready. थोड़ा mood भी देना coagulator. Now see, that is the attachment. Yeah, give me through biting. Through biting. See, what I am taking is a through biting. Not very sharp. लक्स देते हैं, कुछ देते हैं, पकड़ने को दे. And this is the component. See this? From
Yeah,
this
we can
area,
see.
from the lateral wall of the nose, I have gone wide on either side. See this? See the underlying bone? It's pretty
Yes.
clear now.
Very clear. Still have it little bit up. Yeah.
Well, that is mucosa. That is normal mucosa.
Okay.
The attachment I have gone on either side and removed completely with the bone inside. See that?
You are with 120 or 120 or
No, just red 40.
Achha.
See this? This is the thick bone behind. That's a normal bone behind. See that?
Yes.
And I have removed the tumor here attached and taken for the biopsy as well.
Yeah.
One side is gone and you don't need a denker for that matter. The moment you find that you can't remove without a good exposure, just convert to denker. Don't think twice.
Coagulator has really allowed us to do the lot of nasal masses much better, especially angiofibromas.
There is no auto machine? क्या बात कर रहे हैं? See now. So the coagulator is no pump with us to control the irrigation. Anyway, see this part is clear?
Yes,
That
very
is back. Now the most important is above.
Yeah.
Let me go there. Coagulator मोड़ के and put इसको पकड़. Part curd. Or more. Yeah, I will go beyond if I am able to remove it under vision. See the lesion and the normal area beyond. Can you see?
Yes.
Or more. दूर से. See this? What I will do here. I will cut through the normal area. See this? I will cut through the normal area. Yes. Now pull. Pakadna. Yes. See the tumor?
Yeah.
See the tumor?
Yeah.
And I will go around it. Go around it.
Beautiful.
See the complete removal?
Very beautiful.
You can see the underlying periosteum as well. Coming out with the tumor. Can you see the underlying bone?
Yeah, yeah. So Satish, you are on coag mode?
Cutting
Or
here.
mode?
Cutting here. I am going literally beyond, all around. See the depth, complete removal along with the margin, but still I will remove this inferior orbital bone because
This is
the
infraorbital
underlying
now.
bone is dangerous to be left behind. So nice.
Satish, you are on coagulator
This
mode?
was the traction given by my assistant, which made me, remove it. Yes, now see. Yes, Ethel.
Satish,
Please.
I just want to know, you are using coagulator mode or coagulation mode?
Yeah, in between, when I had to cut, I used the ablation. See now, I'm using the ablation over here. See the margin.
Yeah, yeah.
See my margin now?
Yes.
Here I will ablate. Funny, yeah. See, I ablated because I want a good margin around and in depth. See now,
Yeah.
the tumor has come.
Beautiful.
See the traction and counter traction, and this
Yes.
traction given by assistant has made me remove this. See this. Leave it, show there. Now give me 0 degree. So it is almost coming out, and I will check the underlying bone and then we'll be through in next 5 minutes.
Yeah, I think if you see Satish doing it, it looks so simple. I think the thing is having a good assistant and having a bloodless field. So coablator does a fantastic job. If you use a debrider, you'll have constant oozing and you won't be able to take
Yeah,
the
that
size
will make your life difficult in ascertaining the disease and the normal tissue.
Yes.
See, under vision.
Yeah, Satish, everything is good.
See this on the floor of that raw area in the floor of the orbit. See that?
Yes, we can see that.
Completely clear.
Yes.
And now finally I will remove from here. Give me the oblator.
So just show your sphenopalatine also, because there are some people in the audience who would like to see that.
Yeah, that region I will show you. Though we don't need to do anything to it, but
Yeah, I
yes.
know, but just how do you locate it?
That's the final cut I'm giving.
Yeah.
So I am far away from the tumor all around.
Yeah, you
See
have
that?
a nice margin.
Now, that is the hypertrophic mucosa. That's it. Now, leave it. Give me, yes, this thing. See now, that is the floor of the orbit bone I told you. See that?
Yes. Yeah.
Though this is not looking involved, but additionally as a margin, because as long as your periorbita is intact, you can safely remove it to stay on the safer side. See that?
Yeah.
Just to stay on the safer side at this bone.
Are you going to send the bone pieces also for histopathology?
Whenever you have suspicion, yes, you can send. But here, in spite of knowing that the bone looks normal, I'm still sending just to stay on the safer side, because see the periorbita.
Yeah, we can see that.
Intact, good periorbita without any issues. See? Now give me a debrider. Give me a drill for a while. See, my job is done. I'll just little bit of the finishing work and I'm through.
Yeah. Satish, also remember to show the sphenopalatine.
Yes, definitely. It's just finishing work. Okay.
Okay, Satish, bleeder.
See all these bone pieces and all these bad mucosa. This is simple idiomatous mucosa. Now give me a good wash. मेरे को दे अंदर.
Satish, you have a
I
bleeder.
will mop the entire region. I will drill. I will show you the sphenopalatine.
Satish, you have a bleeder there. You want to show how to manage that?
How to?
You have a bleeder.
Manage.
Look at your bleeder there. You didn't notice?
Pardon, I couldn't get your question.
Sphenopalatine की उधर देखो bleeder है. You want to bipolarize that, coagulate that. What do you want to do?
देखता हूँ.
There where your suction is.
Yeah, this one. This will I coagulate. There's hardly anything. See now, above the sphenopalatine. See that there's the attachment of the turbinate, the posterior end.
Yeah.
Can you see this bone? That is
Yes.
crista.
Yes.
That is crista. And if I elevate there, just above there, see, that's the perpendicular plate of the palatine bone. And see, just above this, oh, that's the sphenopalatine branch.
Yeah,
See
it was
that?
bleeding. That's what I told you. It was bleeding till you touched
Yeah,
it.
yeah,
It
that's a
stopped.
small branch from
Yeah, I
it.
know.
That's not the main vessel, I would say. And you can easily control it. See this? Yeah. See now, for everybody from anatomy point of view, band kar pani. This is perpendicular plate of the palatine bone. Can you see?
Yes.
This is the orbital process going to the floor of the orbit anteriorly. See, this is orbital process.
Yes.
And behind, this
Oh.
is your sphenoid process. See this going behind up?
Yes.
In between this is the sphenopalatine foramen. Can you see here?
Absolutely.
And this bone is a thin bone, that is crista. You can remove. See this again. This is perpendicular plate of the palatine bone. It has two processes going up. This is orbital process anteriorly going to the floor of the orbit, contributing to the floor. And that is the sphenoidal process. And in between them is the sphenopalatine foramen, which is, above, close by the body of the sphenoid.
Yes.
So this is this is converted to a foramen, that is a sphenopalatine foramen, and you don't need to do anything to it. Now you have a good area. What I will do, this bone, though I have removed the, periosteum over it, the periosteum was looking absolutely free, yet I want to do something to the underlying bone because you can't take a chance in such a scenario where you have almost given a cure.
Satish, infrared now is seen so beautifully.
Yes, very clear. See there laterally. See what I'm doing? I'm just with this high speed drill, this elevated bone. See, in papillomas, you are always suspicious of a bony projection, which may contain tumor component. So I am removing this bone thoroughly, for not leaving any chance behind. See this? Now it is looking very flushed, very healthy. No tumor, though earlier also we didn't have any doubt of this tumor, but yet doing this completely, rules out the possibility of any. You can see the underlying bone better now. Can you see?
Yes, we can see it beautifully.
See almost, this is how you can, papillomas in a planned way, you can give a good cure to these patients with MRI and all this planning. This is periosteum. This is all orbital periosteum. You are not supposed to do anything. As long as periorbita is intact, don't bother about anything. No, nothing will happen as long as periorbita is intact. No orbital symptoms you can expect. If the periorbita is gone, some fat is prolapsing, then you can think of ecchymosis or something. But here, as long as periorbita is intact, nothing. So to me, this is all about this case. Any questions? See, with this kind of exposure and this kind of tumor removal, you don't need any radiology in the future. You just put your 0 degree in your office and you can get to know any development happening in this region in the future. You don't need radiology at all. Yes.
Excellent
Yes, Atul?
demonstration, Satish.
Thank you everyone for your patience, attention.
Satish, Dr. Pilu Hakim is asking if the margin comes positive, then what do you do?
If the margin turns out to be positive in this case, since we have done a wide resection, I went around for a couple of millimeters around the lesion onto the normal mucosa. I don't expect in any given situation here the margin to be positive. Margin will come positive when the lesion turns out to be malignant, which is most unlikely. Yes, Considering that even the remotest situation, we have taken the margins all around. So I don't see any margin positive, but yes, if you say in the remotest possibility, if the margins are positive, you have to go back and revise it. There is no doubt about it. Like any other oncological case, if your margins are positive, you have to immediately revise it. A positive margin is something inviting a problem. There is no doubt about it.
Okay, thank you.
Just say, I'm at your disposal. अरे कर दिया पैक, कुछ नहीं करना. ठीक है ना?
Satish, is the next case ready? Are they showing that?
हाँ जी, आ जाओ. बढ़िया. कोलेस्टेटोमा, हाँ जी, हाँ जी, हाँ जी. बहुत ही बढ़िया.
देख रहे थे?
हाँ बिल्कुल. यस, ओके. पुट ऑन करें. आप भी रहना सतीश. हाँ, ये अच्छा हो गया इसमें डालने से ना, वो तो दिख ही नहीं रहा था.
I'd like to call Sangampal sir to felicitate our moderators, Dr. Hetal ma'am and Dr. Narayan Jaishankar sir.
हाँ, सात स्टूल. Bilateral unsafe here. कौन सा लेफ्ट है? नहीं लेफ्ट. तो लेफ्ट लिया ना हमने, राइट हमने लिया लेफ्ट लिया. ओके. इज इट ऑन? हेलो. ओके. ओके.
Yeah, Madhuri,
Yes sir.
you can get on with it. You want to show us some CT scan or what?
Oh, yes, CT
Yeah.
scan. The patient with bilateral unsafe chronic SOM, and we are operating on the left side since last 3 years. Tuning fork tests are Rene is bilateral negative and Weber's is central. So has she shown some image of the ear? Or there is a atic retraction, grade 3 on both the sides. So we are choosing the left side. So as we can see.
What is the case?
Hello.
Ah.
It is a grade 3 atic retraction, left side, and audiometry is showing 30 dB loss on both the sides, and we are coming to CT. So this is a axial cut from superior to inferior side. This is dome of the superior semicircular canal, anterior posterior limbs coming down. What we see basically in cholesteatoma disease is external ear, middle ear, internal ear, petrous apex, and basically the facial nerve. So if we keep going down, superior semicircular canal, the mastoid air cells seem free of disease. There is slight haziness there, but antrum seems to be filled with the soft tissue. On this side, it is clear. So disease is more on this side, left side. So further, there is appearance of the interauditory meatus, basal turn of the cochlea, and the appearance of the semicircular canal. There is a facial nerve becoming labyrinthine portion, first genu, and the reverse as a tympanic segment. We are in the antrum. It is filled with the soft tissue disease. This is head of the malleus and body of incus appearing. The semicircular canals appearing. This is lateral semicircular canal. Again, further the facial nerve is coming this way. Intact lateral semicircular canal. There is no erosion of the labyrinth or cochlea normal. This is the ice cream cone appearance of the head of malleus with the body of incus. Now going further down, we're following it. Again, there is only space anteriorly, clear space. Otherwise, there is all soft tissue around. Coming to all this, mastoid air cells seem slightly hazy. Otherwise, mastoid seems normal. It seems this is a localized disease up to attic or the antrum. These are the ossicles. This is cut section of handle of malleus, and this is long process of incus. But here you can see stapes seems to be missing. On this side, other side, you can see the stapes, appearance of stapes there. Here it is totally missing, and there seems to be disease there, but incus, long process, and stapes suprastructure seems to be missing in this case. This whole disease is occupying this area of retrotympanum, epitympanum, attic, and antrum. So, going further down, still no stapes is visible. So, going further down, this disease localized here. Rest of the things are all normal. So, and this is the lower part. Jugular bulb is quite low down. So, we are not having any abnormal finding there. So, in this case, we may be finding the cholesteatoma reaching up to the antrum. And the facial nerve seems intact. There is a bone over the tympanic segment of facial nerve. And the only important thing is ossicles, which stapes seems to be missing and long process seems to be eroded. So as Morwani sir has taught us all, we will go by inside out technique. And I'll show the appearance of tympanic membrane and retraction pocket directly in the attic. Basically attic retraction or this is cholesteatoma is congenital or acquired. Anji.
Madhuri, in
Yes,
this
sir.
picture, you can see the drum on both the side. On the side of the disease, you can see retraction there of the drum in the lower part also. You can see the drum on both the sides.
Yes,
In
yes.
this CT, you can see the drum, and on the left side, the drum is retracted.
To pass tensa is intact all around on both the sides. It is only localized retraction pocket going through. Basically, in attic or epitympanum, there is an area which is least ventilated. It is called the Prusak space. It is between the laterally it is the formed by the pars flaccida, medially neck of malleus, and superiorly formed by the lateral malleolar ligament. So in this space, first the retraction happens. That is the first stage. Second stage is when it goes and touches the neck of malleus, gets retraction. Grade 3 is when the scutum starts getting eroded and slight erosion of scutum is there. And grade 4 is when it goes inside and reaches up to attic, antrum, or mastoid cavity. So we are going to go by post-oral approach as we usually do in our cases. And the planning is to go by inside out attico-antrostomy. And then we will reconstruct the posterior canal wall and the ossicles itself. Okay, over to the surgical side, sir.
I would like to request Dr. K.T. Patil sir to be the moderator for the session. Also, I would like to
Also, I would request Dr. Farida Wadia ma'am to moderate the session.
As till they come to start showing you surgery, I just want to give you information which I have come to know only about a few weeks back. About 5 years back, there was one Chinese fellow. He came to Otology Society meeting, and he said after the endoliphatic sac decompression, the hearing improves. After endoliphatic sac decompression, hearing improves. So I had never done audiogram of any patient after a long time. So since last 4 years, I've been doing audiogram of my patient, and you'll be surprised one patient has got no hearing loss at all from 60 dB, and all of them have improved. So I said, if my patients are improving with endoliphatic decompression, so I told one of my residents to go and see what is the effect after gentamicin. The gentamicin, we know it gives a toxicity. That's different. Do the long-term hearing improves? And there's a literature suggesting the hearing improves even after gentamicin. So when you control the eye drops, whether you're controlling with the surgery, or whether you're controlling with a vestibular neurectomy, or whether you're controlling with gentamicin, and then after that, I told them to now see if the medical line of treatment also improves hearing. And they showed me the paper. This is 3-4 days back. Otology Society meeting में जाने के पहले I have told her to find out about gentamicin. After I came back from that, so I said, is there any literature saying that hearing improves even with the medical line of treatment? So the concept is, it doesn't improve in every case, number one. It may improve, some series says from 30 to 80% people's hearing improves, and it doesn't improve immediately. It may take 3 to 5 years to improve. So this is a new information which I wanted to share with all of you. Okay. So, see what happens most often case of vertigo, whether you with medical line of treatment or gentamicin or endoliphatic sac decompression, they don't come for follow-up. You know what I mean? And when they're coming for symptoms of vertigo or tinnitus, they are least interested, they least complain about the hearing impairment. You know what I mean? So that's why probably we are not, all of us has never noticed. It's a new information from my point of view. So I wanted to share with you. Now I want to give one more information till they start the case. In 2000, I did one case of facial palsy, which was 7 years long standing. Patient is discharging here, conductive loss, and cholestoma, residual cholestoma. So I told her I'm going to do surgery for cholestoma surgery, And when I went and did a surgery in vertical pose, I saw about 3 to 4 millimeter gap in the facial nerve. There was no endoneuroma, there was no ischemia, there was no fibrosis. It was looking so healthy. And I'm quite eccentric, I call my facial nerve as my mistress. वो तो मेरे को बोल रही थी, मेरे प्यार तू किधर है यार, मैं तेरे लिए बैठी हूँ, आजा. So I went and did a grafting, and after when she used to come for follow-up, I never used to think, यार मतलब eccentricity कर दिया. After 7 months she comes, देखो सर अभी हिलना शुरू हुआ ना, देखो, and I have video of her. She has improved so dramatically, you can't believe it. So, this concept that facial nerve after 2 years, people used to say after 1 year, you cannot do anything to facial nerve. Then the loud literature talking about 2 years. Very few people are talking beyond 2 years. In 2014, we had a 100 temporal bone dissection workshop. I did one case of facial nerve, which was grafted twice. You see, immediately it was grafted, and after 1.5 years was grafted by other surgeon who was a fantastic otologist of a country. He only referred me the case because he had heard about my 7 years this thing, He referred me the case. I had done a surgery on that lady also, and she had done tremendously well. So I used to always say, I used to compare the what you call facial nerve to the woman, for example. Sometimes your negligible injury to the facial nerve can cause you palsy, and sometimes the gross injury may not cause you palsy. So this is happening to facial nerve. So this patient, second patient which we did, I think if you remember, when he had done a grafting from the, let's say, somewhere from pyramid process, not pyramid, from the processor cochlearformis to the vertical course, what happened, the processor cochlearformis area, the horizontal portion was beautiful. You never thought any suturing done. And this facial nerve was stuck to where I was mobilizing the cavity skin. Arun Agarwal and Achal Gulati were the moderator. I'm mobilizing the skin of the cavity, and they asked me, can you identify would you tell them where's the fashion now? So, and that's it. I was not thinking of looking for fashion now. And luckily they told me that the fashion was adherent to the skin of the posterior cavity. And I could dress it beautifully down to the healthy. And there was a lot of fibrosis around it. So what had happened, because of fibrosis, the skin had elevated a little bit and just at the level of so at the level of the stylomaster foramen, just 2 millimeters away, the facial nerve had the graft had come up. So what we did the removal of fibrosis, and I created a tunnel. And that time I would tell the Rahul to do a suturing. See, I have always, like all my good, I was talking about stapes surgery. Similarly, all my registrars, Sandeep Karmakar, Sanjay Bhatia, Narayan Jaishankar, all of them done facial or suturing. And in fact, once what happened, I was trying to do suturing in CP angle. And CP angle, there's no sheet. So now it's more fragile. X stitch cut through, third stitch cut through. Sandeep was my houseman. I told him, will you please try that? See, if I can't do it, why can't you give chance to somebody else? He did it, and first go, he could do the stitch. So don't have a superiority complex about yourself that you can, what you cannot do, nobody can do. You know, this is what you have to be very practical about situations. Sometimes you may be exhausted or, you're tired or whatever you're. So again, the message is teach your students all these things. In the workshop also, I allowed him to do the suturing. Anyway, the lady, after 3 years, also she improved. I done 2 cases of facial hypoglossal after 3.5 years and 4.5 years. And one was case was done again in the same workshop, and she has also improved. So my message is, don't give up on facial now. What harm you are going to do? Maximum you are going to take a greater auricular nerve, and maybe paresthesia will happen in certain area. But otherwise, you cannot do any harm.
Grade 4, grade 5.
Grade 6, all grade 6.
So if it is grade 3, then
Grade 3 give up on certain moment you give up better.
इसकी लाइट और बेटर हो सकती है या दिस करता दो एक बार स्पेकुलम दो
There is 2 ways. एक तो depth से
कम हो गया
Okay, Madhuri, we are ready for you.
yes sir okay sir. Hello sir.
Good.
Yes, good evening, Madhuri.
Good evening Farida, good evening, nice to hear you.
And nice to see you too.
Thank you.
Lower end, we just sutured it. We sutured it because we created a tunnel. So there was not much of gap. We know first surgeon had taken a greater auricular graft, second surgeon had taken a sural graft. Here, luckily, we did not require a graft. We could reroute it and put it.
Speculum. So, Dr. Farida, this is a case, this is the left ear of the patient, and I am trying to show just sir was mentioning that CT is showing more retraction of the pars tensa on the left side.
Right.
Is it okay? Can you see?
There's too much of glare.
Okay.
It's okay for timing.
Yeah, this is better. We keep feeling as if somebody has not done the white balancing, but I'm sure they have done it.
नहीं किया नहीं है किया क्या white balance अभी भी नहीं किया कर दे
white balance नहीं है.
इसमें जैसे इसमें नहीं है
Okay.
This is left ear.
This is left ear.
Under local.
नहीं under GA sir.
Okay.
So I am trying to focus it on the attic retraction. It seems quite deep there.
Okay. We can see the PSQ region, still not seeing the attic.
This is the one.
Okay, done.
Can you see?
Yes, we can see. Yeah, now it's
Legs
clear.
are there. This is
Yes.
the handle. This is the lateral process of the malleus. This is the neck. This is the long process of malleus, the handle of malleus.
Right.
Lateral process, and this is the Prusik space where you can see the retraction pocket. It's visible?
Very, very well.
Acha, okay. So now we'll shift for the post-oral route where we have already taken just to save time. So I already given post-oral incision. Almost we these days give in the groove only. Okay.
Okay.
Groove of the post-oral. Okay. एक gauze piece दें. So already the incision was given and graph was taken by Dr. Apurva only. So after that, harvesting the graft, forceps देंगे. So what we do is we to raise the musculoperiosteal flap, what we have done is this is the posterior margin of the bony canal. So one incision is given here in a curvilinear manner and one between the temporalis muscle and the postoral muscle, and we have raised a postoral posterior inferiorly based cautery दें.
Right.
Base flap, and now we will lift because this is for a inside out mastoidectomy. We don't give myototomy incision at the margin of bony or cartilaginous external canal. Okay, in routine when we doing tympanoplasty, we give a myototomy cut here.
Okay.
So here we don't give. We
Okay.
just lift. The important thing is in cases where we need to do obliteration, we use this skin which we lift as a single layer, not cut in between. Myototomy can make it divided into two parts. So that way it is not septum elevator. So we don't give a cut here.
And you elevate it down to the annulus, right?
No. Yes. I'll give at the annulus only. No, septum elevator. So this is the location of floor cartilage. Can you see there?
Yes, yes.
It is visible. Let me focus.
Yes, it
Okay.
is visible. Yeah.
This is the floor cartilage, lower extension of the conchal cartilage, and this we have got a lot amount of this cartilage which can be used for ossiculoplasty, obliteration, or reconstruction of posterior canal wall. And also when we remove this, that releases a lot of skin. When we do myotoplasty, this part of the skin also becomes available for the myotoplasty. So this piece can be used or discarded as and when required.
Done.
Okay. अब वो दे मेरे को. So with the septum elevator, I am separating the skin of the external canal without giving myototomy incision. Light is less. Can somebody increase that? Whenever there is a glare, kindly let us know so that we will reduce the light also. Wash करेंगे. Okay, suction. Cautery thing. Inferiorly, you need to separate some fibrous bands to release the skin there. फिर से देंगे septum elevator.
You know that principles. Yes. Carbon dioxide. Yes. I think illusion.
So I have reached now the annulus of the tympanic membrane,
Yes,
and here
yes,
just
yes.
lateral to that. अब मेरे को retraction देंगे. I am putting the self-retaining mastoid retractor there to pull the skin anteriorly, and then I will give the incision at the level of tympanic membrane annulus. Sickle दे दें. I'll make a entry there. No, sickle. No, perfect, perfect, perfect. You're great, yeah. So I'm making an entry there.
Yes.
Lateral to the annulus. Okay, now give me scissor. Micro scissors. So that way 3/4 of the skin of external artery canal can be lifted nicely. And
Agreed,
we
agreed.
may not need to do any myoplasty in this, but once if we need to do, just see how much skin can be available.
Right.
This much skin without cutting and scissors, micro scissors. Iris, do we have iris scissors? I have it in my set only. So till then, give me microscopic scissors. You arrange for that. Superiorly, I am separating it. Now this is the technique where, because we leave the tympanic membrane behind, we are not doing a tympanomeatal flap, we are just lifting the meatal flap. Okay. So
Okay.
wherever there is a retraction pocket, sir's philosophy has been not to disturb it till you expose it in all dimensions. So if I lift the tympanic flap as well, so I'll be cutting through the retraction pocket, which is not, does not come under the philosophy what we operate for cholesteatoma. Knife dena. So we leave the retraction pocket there till, and that is what inside out mastoidectomy is all about. No. Okay. Just don't disturb the continuity of the atic retraction. Table thoda upar karenge. So once I lift, another benefit of not giving incision there at the outer bony and cartilaginous junction is that we lift the whole, this thing, whole flap anteriorly. It does not come in the drill. So that saves the cutting of the.
See what she is doing. She will be exposing atic till 1 o'clock position, right in front, okay? And floor almost up to 5 o'clock position. And then she'll put a, for demonstration, she may put a small roller gauze to bring the skin out. Thin roller gauze, half an inch roller gauze you can put.
I can do that, or I can just lift it anteriorly
no,
like that.
no, what I mean for demonstration, you better do that, because when you're doing surgery alone, you don't
Yes,
have to
Madhuri, do
demonstrate.
that because it makes the feeling.
Yeah, this is just for demonstration. You are too good, we know that, yeah.
No, sir.
Bribe देना मेरे को कल अच्छा बात कर रहा हूँ तेरे लिए.
अच्छा ठीक है sir. Okay, now the flap is away, washed in. So now we have a wide view without the skin coming in between. And when I move the burr here, it does not get entangled here because there are no cut margins.
Okay.
So give me cotton ball. So now once I have lifted it, next step is the most important one, which is canalplasty, which forms the most important step of this surgery. Because canalplasty once exposes all the quadrants of the tympanic membrane, and then after canalplasty we'll be able to go around the atic retraction all around. So a wide canal is required for inside out mastoidectomy. Chota dena thoda. Chota cotton. Okay. Now I'll go ahead and do the canalplasty. This is the retraction pocket. Can you see there?
Yes, it's very clear.
Drill there.
Madhuri, I was not there when you showed the audiogram. What is the hearing loss?
30 dB, sir.
And see, Madhuri, I remember Madhuri showing CT scan, showing that she cannot see the stapes properly. And there's a probably suprastructure is missing, right, Madhuri?
Yes, seems. Suction.
See, now what happened with 30 dB, suprastructure missing is less possible.
Yes, you are right.
Second thing, the CT scan taken which cut. What is the thickness of your head of the stapes? So sometimes you may miss it also. You know what I mean? There may be continuity, you can miss it also. So, and sometimes other thing can happen. Sometimes cholesterol has a continuity for hearing for you. Sometimes cholesterol
yes,
is causing
absolutely right. Yes.
Yeah.
We're just getting the suction. I will just release it so that we have a good enough space for canalplasty. एक और भी देंगे self retaining. इधर से डाल देंगे.
ऊपर से देखो एक female bleeder आया है. I call male bleeder and female bleeder. The bleeder which gets coagulated once is a male bleeder, which will cut twice, thrice, four times is a female bleeder.
Bipolar. Bipolar है? No.
And
और आर्टरी दे दो मेरे को, आर्टरी से भी तो.
Bipolar, bipolar.
No, it is not. Okay. No, it is not okay. Can you give me artery?
now it's very clear what is male bleeder and what female bleeder.
करो, आर्टरी करो, मोनोपोलर. करो. Why आर्टरी is not okay? कम है शायद. आर्टरी बढ़ा देंगे. करो. हाँ, perfect. और दो. गीला गॉस पीस दे देना. वॉश दें. ये ले. Okay. Now circular knife. Now to assess the depth of the bone which needs to be drilled for canalplasty, we use this circular knife. Just see there is no canal hump there, completely visible. And anteriorly also there is no hump. So we don't need to do any canalplasty there. We just need to widen it here. Okay, this is the inferior part. Here also the annulus is neatly visible. So this area comes under the canalplasty. Canalplasty is started from lateral to medial side in a C-shaped manner, starting with cutting burr from outside and going deep when we shift over to diamond burr. So almost 2 to 3 mm burr, cutting burr first I'll take and then I'll take the
Diamond burr. Okay.
So it should be a strokes, single strokes rather than, no, one side smaller. Not the small repetitive movements, should be long single strokes for a good canalplasty. I'm starting from lateral side. पूरा टेबल ऊपर करके और ऑपोजिट साइड को घुमा देंगे.
If it's not too bad for you, yeah, centering would have helped. Yeah.
Oh yes, definitely. हाँ, थोड़ा और ऊपर.
Madhuri is a very good painter, so all her drilling work is like painting strokes.
Oh, thank you very much. Okay, bye.
Something
Is it
about
better?
Madhuri, I'm going to praise you. Keep your ears closed, okay? Madhuri came to do a temporal bone dissection around 2002, 2003. When did you come?
No, it's 2005. Sir.
Okay, whenever she came. Naren came running to me in about half an hour. Sir, this girl is going to finish the temporal bone in half a day. She was going so fast and so smooth because we are always short of temporal bone. We didn't want to give a temporal bone to her. So he said, you control her, you know. So you know, if you make the people go this more systematically, see, the problem is, as I mentioned yesterday also sometime, that if you are too busy, you automatically become fast. Let's say what surgery I should do. Let's say 30 years back, I was much faster surgeon. 20 years back, I slowed down. 10 years back, I slowed down. Not because of age, because the number of the cases to be done were lesser. You know what I mean? So you become fast surgeon out of necessity, like Satish Jain is fast surgeon. It's out of necessity you become fast surgeon, you know. So she was very good dissector. When we went to Mario Sanap, you were there.
The best dissector.
She was the best dissector. Mario brought every fellow of his to come and show, and he took her specimen and kept it. So this is what Madhuri is.
Thank you. All because of you, sir.
Then
All because of you.
2005 के पहले तो मेरे को पहचानती नहीं थी.
Sir,
Okay?
बिल्कुल मैं उससे I would not have come out of my house and system unless until you had pulled me out. I would have been happy there. So you gave me the confidence, courage that I can do well, and that's what is keeping me up, sir. Thank you for everything, sir.
Yeah, we had also arranged a dissection for all the participants, skull-based dissection. I said before we about 20 people went. Vijantan was one of them. She was there. Farida was there. Vandana was there. And Sonal Modi. They're the 5 girls. Mohan Reddy from Hyderabad, who's an endoscopic surgeon now. He was there. Huh? Uppal was there. There were a lot of people, We had a great fun also. On first day, we'll.
Okay. Now, हमें छोटा दें 2 or 1 mm.
And before
Sorry,
going for the dissection session to Mario, sir had arranged a dissection session at Mumbai. So people were asked to come one day earlier before leaving, so that at least we make a good show at Mario's place.
We don't make a fool of ourselves, right?
नहीं diamond दे दो थे. Diamond दो.
Lateral skull base means you need a skull. The section was not on temporal bone,
Dr. Atul also had come to teach us. No? The
Yes, I remember.
Yes.
And who else can do, Farida, like this, creating a same situation in Mumbai and letting us drill and do it and before going to Mario Sana?
Only Dr.
Only
Marwani.
sir can do. Only sir can do. So, okay, this canal plasty is over now. I can see all the margins around, inferiorly also. So now I'm going to drill around the attic in inside out. Now this was canal plasty, lateral to medial. Inside out is medial to lateral. But we don't keep drilling here. What we do is we start our drilling from anterior most part in a circular manner and outward manner. Okay? Can speed be increased? Speed is too less. And also a bigger, I need one bigger size. Bigger, one size bigger. Huh. Now in a C-shaped manner, we keep drilling from inside out in a way that we don't go towards the important structures, rather keep coming out. So that is as sir has been telling, this is the least dangerous technique. Outside in drilling, when we come from outside in, then we tend to go towards the important structures and cause trauma there. In this technique, we keep going away from the important structures, so least chances of injuring them.
For example, low-lying dura is advantage here. Forward sigmoid sinus is advantage there. Why? Where these two structures restrict the quantity of disease, So this is the other thing. And you are drilling on the canal. Only fallopian canal can be identified without dissection is only horizontal portion. You cannot identify vertical course. So when you're doing this, and similarly, the chances of damaging lateral canal are negligible because you're working outwards all the time. You're not going towards the attic antrum.
Also, the important use of circular knife. Can you give me circular knife? So circular knife gives us, we can gauge the height of, just see. If I put it there, can you see how far superior it has gone?
Yes.
That means the tegment lies quite high. So we should not be terrified now. This much depth is already there. This much depth is there. So I can keep drilling around without causing any trauma to tegment.
Right.
Okay. Then I drill.
Madhuri, why you are doing diamond drill?
But I'm just shifting over now to the cutting. I was close to the important structures. That's why I kept the diamond drill. Now I'm shifting over to cutting the same size. Now we have shifted, sir. As it is, we are showing it because everybody should be knowing. Using
normally
cutting,
we-
but there.
Normally, we collect the bone dust when we're expecting a big cavity. Now here she thinks that disease is restricted to the attic or
बंद हो गया?
antrum. So she's not collecting the bone dust. Okay, otherwise you will be washing this area with a drop saline and collect the bone dust.
So, sir, there are three areas from where we can harvest the bone dust. One is while doing canalplasty or inside out antrostomy. Other is from this this lateral surface of the mastoid bone, squamous temporal bone. So all three areas we can harvest a lot of bone dust there whenever required. So this area we have to keep away from the disease part because we don't want any smallest bit of disease to be included in the bone dust we have harvested. So this area, when I come out, and if I feel like, I will harvest the bone dust from the lateral part, not the medial part. दोबारा ना?
Would your approach have been the same if the attic was normal and you had a deep-seated posterior retraction pocket?
Yes, yes.
with the-
Absolutely. Then we will, what we'll do is partial aticotomy.
Okay.
Wherever the disease leads us, we will just follow the disease. Whatever smallest, even a retraction pocket will be handled like this only.
Okay.
If
So
we
that
have,
makes,
sorry, if you have mastoid fistula of somebody, then a CT scan shows a gross destruction of cortex, then you can go outside. Idea is follow the disease, as simple as that.
this technique is simple because it has fixed principle of following the disease. That makes the thing easy, and we don't break the continuity of cholesteatoma sac. We will keep removing the lateral wall of the sac, but never touch the medial wall of the sac till we expose it in all dimensions. So simple.
And most important, the acquired cholesteatoma always starts in the attic, Pushka space. So better follow the disease where it starts.
True.
Give me curate. Because I don't want to rub my ossicles till I know that incurostable joint is intact or not.
Madhuri, 1 minute. Don't do that. 1 minute, just a second. Madhuri, see,
Hmm?
can you see a sac or a mucosal fold anterior to the malleus?
Yes,
Yes, of course.
See, in every
Antidiabetic
case of
balance.
cholesteatoma, there's some ventilation pathway blockage from anterior aspect. Okay. So there's a blockage you can see now. Okay.
Yes.
So that way, by doing this drilling, we first expose the anterior most part of the cholesteatoma sac, as sir has mentioned. Can you see?
Yes.
I have reached the anterior most edge. Can you see there?
Yes, it's very
You can see
clear.
the epithelium going in the depth over there in that area.
Yeah.
And now I am going superior. We will keep following the cholesteatoma from anterior to posterior and superior. So now I am following it in the superior part till I reach the uppermost edge. I'll keep drilling and keep feeling the tegmen bone by putting a circular knife there. Can you give me circular knife? So that we are sure that we are not going to suddenly hit the tegmen bone. You see?
Yeah, you have space still. Yeah.
Okay. Give me drill. Just see, when I am drilling inside out, I am keeping only removing the lateral attic wall. So there is no danger of hitting any ossicle or the facial nerve as such, facial canal. Because
Understood.
I am just removing the lateral attic wall only. Okay. So this is the superior edge we have reached. Can you see there?
Right.
Diamond dena. This is the superior edge. Okay, the centering is not. Abhi, just wait. I just want to. By running a dry bar, I am trying to control the bleeding from the surface of the bone.
Right.
Okay. पानी था चलाई
बाहर कुछ पानी पूरी खिला रहे हैं, बोलते किसी को खाना है तो खाने को। बॉम्बे में आते लोग पानी पूरी खाते, चला इंदौर कर। अब तुम्हारा वो कौन सा गली है, 36 दुकान ना, हाँ 56 दुकान in Indore. You get all kind of food so beautifully over there, you know. How Gali is in Bombay. There was in beginning of Kalbadevi area.
Okay, wash.
Now you need to center.
Okay. थोड़ा मेरा स्टूल इधर कर दें slightly. It's okay now?
Right. Perfect.
So you see, I am a circular knife देंगे. So I have to see how deep I have to go there. It seems the dome of the cholesteatoma is reaching. It is going deep down. Give me the ये थोड़ा पास ला दें. बस हो गया. So this sac is leading us to wherever it is going and we are just following it.
Right.
So if you give me a sharp instrument, I'll show you where you tend to find the fallopian canal, because blindly you cannot be going. We have to keep assessing the surrounding landmarks and the important structures around. So एक मेरे को वो देंगे. हाँ.
Need to center again.
Okay, wash. Okay, give me sickle. Okay.
Right.
Okay. This is head of malleus.
Right.
This is incus. Can you see?
Right.
Body of incus. This is short process of incus. Okay.
Right.
So the facial nerve, which takes a second genu and turn, becomes a tympanic segment. It lies medial to the incus. So imagine so that's why important thing is try to remove ossicles slightly later on when you have identified all the structures, so that you don't cause any trauma to facial nerve generally. But if I keep drilling lateral to it, so there is least risk of injuring that. Okay.
Okay.
So this is the lateral wall of the cholesteatoma I have removed bit. I am keeping the medial wall intact, following it, and I am about to reach the dome of the cholesteatoma then. So this does away with unnecessary drilling of the mastoid cavity or mastoid air cells. If the disease is limited, we will stop our drilling there only.
Okay. If you had an intact incudostapedial joint, touching it with this burr would give it SN loss?
No, because I am keeping away, and when there is we are expecting, then what I do is give me curate. The bony ledge, I'll just drill on the lateral surface of the bone, keeping a bony ledge beneath it, and then remove it with the curate.
Okay. Curate. So
Rather than causing any jerk to the ossicles. Okay.
Okay, beautiful.
Wash. So after thinning the ledge, we can very easily do it with the curate forceps. Okay. So now we have cleared it. Forceps. The short process of incus is visible. Can you see?
Yes.
And this is cholesteatoma sac. Can you see that?
Yes, yes.
Beautiful. Dena and drill. Can you see the cholesteatoma sac beneath?
Yes. It's an intact sac, done beautifully.
Thank you.
Do you intend to lower the facial bridge simultaneously?
Yes, yes. Facial ridge does not form at all because we keep lowering it along with. Facial ridge is basically creation of surgeon. It is not a anatomical structure. And because we come from outside in, that's why we create first a bridge and then break it. So we keep lowering it down along with. And I am only removing the lateral bony wall. Nothing doing with any important structure down there. Centering है. No bony ledge. Another important principle is while doing this, we tend to scoop out the cholesteatoma from under bony ledges. In this technique, we don't leave any bony ledge lateral to the cholesteatoma. The first important thing is to keep drilling away all the bony ledges lateral to it by palpating it with a circular knife. I will show you how. Give me circular knife. Okay, this is the sac. If it is slight, can you see, Farida? There is slight bony ledge there.
Right,
So I'll drill it away rather than scooping it out.
Okay.
So bony ledge is out, everything visible. Then bit by bit, we take it out in toto towards middle ear. And that also I plan to take out in 3 parts, cholesteatoma sac. First, from antrum towards middle ear at the level of horizontal fallopian canal. Then second is removal from the anterior attic, and third is from the middle ear. So in 3 parts, I remove one by one after exposing it completely. So I'll show you how I do it.
Okay.
That way, there is not a single bit of cholesteatoma left behind because we aim to have a doctor-free, friendly cavity middle ear for the patient with a good hearing. So it should be doctor-independent cavity he has.
Okay.
For that, we have to remove if we don't want a revision case in future for the patient. Just see. I am remove. Now, can you see circular knife? What I was trying to tell, that this bony ledge is out. It is visible.
Yes.
Okay. So we don't do anything which is under the bony ledge. Cholesteatoma should be removed under vision, not blindly. So as I'm coming out, I am already moving from important structure, away from important structures. But as it was showing, it is going more deep than what we were expecting this.
Yes.
Till the dome is about to come. Bas.
It's bigger than what we estimated.
Yes, yes, yes. Yes.
Mm.
सेंटरिंग ठीक है कटिंग है ये डायमंड है कि कटिंग है मेरे को कटिंग दे दो so it is lying I can even pinpoint the lateral semicircular canal एक sharp instruments लोगे bulge I can see there this is the keratin layer I have removed okay cholesteatoma sac has got two layers Farida first is matrix other is submatrix. The matrix secretes the non-cellular part, which is keratin, which the muck which fills the sac, and I have just suctioned it out. And the submatrix keep eroding the underlying bone. So this is passive expansion and erosion of bone around. This is how the cholesteatoma sac grows. So now almost everything is open. Just this part needs to be open. Now I need a cutting bar.
So you will remove the matrix under complete magnified vision, right?
Yes, yes, yes. Every bit of cholesteatoma should be out, and then I will decide whether I need to go inside intact canal wall or canal wall down.
Okay, done.
If I find up to antrum, I will definitely try to reconstruct the wall. But if it is going further than antrum, then I'll have to do the canal wall down. So let me see.
Sure.
Hello, madam.
Yes, sir.
You see, when you start doing inside out, you are already committed for a canal wall down.
Yes.
No, she means reconstruction. She means reconstruction later on.
If I find that it is okay, the posterior canal wall I could save after removing the cholesteatoma sac. I would rather reconstruct the posterior canal wall than giving a canal wall down. So let us see, huh?
Okay.
We will decide together, whatever is the situation. Now I think the end is coming. So I can see the dome ending there only. I'll show you. Okay, slightly more. इसको थोड़ा और wide कर दूं.
So your aim will be to go 2 or 3 millimeters beyond the matrix, right? Lateral to the matrix, where it ends.
Yes, yes, lateral and around till we reach the end in all direction. Then I will do the mobilization of the sac.
Okay, done.
Can you see?
Yes.
Almost reach the outer end. Give me the. Circular knife. A small bit of ledge needs to be removed. Can you see? Only this much. And slightly on this side. Then outer location. Okay. Wash. Now I think I have reached the end and we will start lifting. Before that, I want to show the whole cholesteatoma sac.
Slightly center.
Okay.
And we can see the posterior end properly. Yeah, that's better.
Put a diamond in. Okay. This is the end. Can you see there?
We could just center it a little, Madhuri, then we'll
Ah, yes.
appreciate.
Oh, okay, okay, okay.
Now that is better. Yeah. वो सेंटर होके वापस खिसक जाता है.
हाँ, ये थोड़ा microscope is slightly dancing type of.
Right.
Stapes में रुला दिया इसने. It moves so much or stapes में you don't.
I could
cannot
understand.
afford. हाँ. I am trying to see whether I am any. Okay. Now give me straight needle, and what I do is usually. Okay. Can you see the outer edge?
Yes.
Can you see?
Yes. Some granulations there also.
Still. So this is it, huh? थोड़ा मेरे को छोटा एक diamond. It is the end I can see. I hope you are also able to see that.
Right.
छोटा. बहुत अच्छे से. Thank you. Doing it quite well. Again, trying to remove every bony ledge lateral to it so that I don't leave behind any cholesteatoma. Okay.
Now over here, the bone is quite sclerotic. Supposing the
Yes,
bone
because-
was well nematized, then what would you do? Would you stop?
I will check the patency of the towards patency towards the mastoid cavity. In worst cases, if the patency is compromised, then what I'll do, I'll small mastoidectomy cortical there to maintain check the patency. I can go to that extent, but this remains the same.
Okay.
Okay, now मेरे को needle दो and small cotton ball. So now what I'll do is I will start lifting from here.
It's a straight pick.
Now this is something broken instrument. You can give something, some slight curved or straight needle. This is some broken instrument. Okay. So here we don't use sickle. No, this is not right. A ball probe de do. We can take a ball probe. Any sharp instrument directly will cause a cut through into the this sac. Can you see now?
Yes,
Chota kar do.
we can.
Chota suction. Because it will, I don't want to leave any cholesteatoma behind. Wash अच्छा सा. A good wash is needed. Bas. Enough. मेरे उसमें होगा बॉल प्रूफ देखो और एक कॉटन बॉल दे दें. There are two kinds of cholesteatoma sac. One is they make a clear sac and they have a very good plane beneath it. And few are कुछ और दो ना मेरा बॉल प्रूफ है या कुछ needle from my set. The other is invaginating kind of cholesteatoma which invaginates into the cells. And that is a bit dangerous because we may tend to leave behind some part of the cholesteatoma there. But once you see in front of your eyes under complete, yes, this is okay. Can you see?
Right. It's peeling away now.
Peeling away. And I know everything is exposed.
Going deep, huh?
Very deep. Superior to the lateral semicircular canal. It is this is one area where there is a chances of recurrence are there or residual because we usually tend to not to drill in this area. Can you see I am showing the continuity? I am in the plane
Right.
Needle दो अरे. Trying to break the fibrous bands beneath it. छोटा सी cotton ball, बहुत छोटे से. So I don't put directly needle there. No, see. Okay. Clean
Right.
plane. So there are least chances of, even if there is a fistula beneath it, we're just creating the right plane and lifting it. And whenever there is some doubt, I will put a cotton ball there so that I don't directly hit any exposed or dehiscent structure. एक ड्रिल दे दो मेरे को, इधर थोड़ा सा बोनी लेज है इधर.
What? What up? I will investigate.
Side knife दो.
Do you intend to preserve all this master mucosa?
I want to preserve it, sir.
Okay.
Because the ventilation happens through this, the most important cells are the cells in the epitympanum, which are at the crossroad between the middle ear and mastoid. So whenever I remove the cholesteatoma and make it intact canal wall, so the mucosal layer should be intact. If the literature says if I leave bits of mucosa here and there, islands of mucosa, that is not going to serve. Whatever mucosa I leave behind should be in continuity to the epitympanum for the mucosal gas exchange to happen. So leaving behind just islands of mucosa does not serve the purpose. If I am leaving, it should be in continuity to the epitympanum. So you will see that I will not disturb this underlying mucosa there at all. It should be in continuity so as to have a good ventilation there for the patient. And ossiculoplasty will only succeed if there is a good ventilation in the middle ear and mastoid. Otherwise, the retraction will be there, effusion will be there, and all ossiculoplasty will go waste. Wall suction tip एक गिर गए. Suction tip दो. Wash suction tip एक on.
Otherwise, by leaving this mucosa, you cannot obliterate also. You are not able to bury the mucosa. Let us see. Exactly.
फिर से ball pro. I have not even touched the incus and I could remove all of the cholesteatoma sac. Just see, I have not even touched the tympanic membrane.
You're right. But you'll sacrifice the head of the malleus, right?
I will, if it is going medial to the ossicles, I'll go medial. The cholesteatoma itself will show. I will now going to take out the incus to see whether, because this cholesteatoma sac is there. Can you see?
Right, right.
And this is fossa incudis. Now this went from, yes.
So that must be
Yes,
serving as the conductive part. And
Yes, sir was saying absolutely right. He was saying why the hearing is not that bad.
Right.
So sir has a, he's curious. He always tries to correlate things, and that's why he is such a great master. So this is fossa incudis. Now I'm trying to take out this incus. It does not have a long process. Can you see? Oh,
Yes.
it is there. Let me see. So what I'll do is, give me iris scissor. So first debulking is at this level. Okay.
Right.
Now it will make the way clear for me. Okay. Wash.
Right.
Now I'll try to look for cauda and the incudostapital joint first. Okay, so then only I will take out the incus, knowing what is happening there. Sickle, small sickle. So this is the lateral process of malleus. We shall the cauda should be here only. Beautiful incudostapital joint is there.
Yes.
Maybe it was hidden behind, but maybe long process. We'll see. Side knife. Now I'll lift it from there because there is no cholestoma. Otherwise, many a times it is mostly in middle ear also extending there, but it is not there. So I'll try to check the continuity of ossicular chain. Sickle. Oh shit.
So your mesotympanum and sinus tympani are clear.
Yes, absolutely clear. Yes, it is absolutely clear. So we can see the cauda also.
Right.
So this is the area where it is going and there is a clean space there. So I'll have to circular knife. So as I told you, I'll not take out, scoop out the cholestoma sac. I'll try to put some, just see this much bone needs to be drilled. Okay.
Right.
Diamond. बस वो देना नीडल लाइट थोड़ा बढ़ा सकते हो क्या Can you see the posterior end?
Yes.
Complete sac.
Right.
इसलिए maximum कौन सा अपना काम?
It's like a pearl.
Yes. Yes, like a pearl. Beneath it is the facial nerve. I can see there. Can you see?
Yes, yes.
So again, this bone needs to be drilled then to take it out completely. Lateral. So we are lateral to the okay, curate then. Now that there is continuity in the ossicular chain, I have to be careful not to do any jerk.
Right.
Okay, now this I have removed. फिर again sickle or needle कुछ भी. We will definitely have to take out the incus because it is going medial to the incus. Can you see?
Yes.
Incus is acting as a bridge, and if I don't take out the incus, we'll not be able to remove the disease completely. So very gently. Let me try. Suction. इसी बंद कर दिया जल्दी से बंद कर दिया
I often feel that it's like this. Can we cut the interest from here with the values here paper and keep this in the कर सकते हो हाँ कर सकते हैं हाँ लेकिन बहुत काम नहीं करेगा हाँ हाँ so then just cut it from there.
So, Farida,
Right. Haji.
I am removing the incus because I can do the ossiculoplasty, but if I leave the disease behind, that will not be good for the patient. Can you see it is going, and this superior surface of the incus is eroded by the disease. Can you see that?
Yeah, so you can't leave it
If I
behind.
leave there, it will be bad for the patient. So first I'll separate the gently incudostapedial joint. Can you see?
Yes, I was just asking Dr. Patil that whether we could leave that joint there and just go a little above chorda and cut that part.
And cut it.
Yeah. Does that work?
We can try that. You're right. एक बार
Yeah.
वो देना
Caesar.
Peleus head nibbler.
Madhuri, absolutely right decision.
हाँ.
Absolutely right decision.
Okay.
Incus needs to come out, but yes, this is also a good idea.
I don't know whether it will work or not. So I've cut it.
Caesar.
Now
Yeah.
give me sickle. Now
Correct.
see, this could not have been cleared. Huh?
No, it had to go. It had to go.
It had to go. So keep this incus. We will see how we use it. So now it has become absolutely open. Forceps.
Beautiful dissection.
Thank you. Now head cutting. Then again nibbler. Because anteriorly you saw that the cholesteatoma sac was going anterior to the head
Yes.
of medial there.
Yeah.
Yes.
Can you see there?
Yes.
So it needs to be out. Head will try to protect the chorda. Sickle. फिर से दो निबलर. Sickle. So head is out.
Right.
Now wash. I will remove every bit of inner continuity, cholesteatoma sac, and then we will think of reconstruction. हम दो मेरे को सिकल दो या नीडल दे दो. So we have left that part. I hope it helps us. Then I will not, I can only, can you see there?
Yeah, too
Yes,
many
sir.
strands coming.
Okay, now you see. This is the second I told you. I remove it after I have debulked the this thing at the level of horizontal part of fallopian canal, the cholesteatoma sac. Now this is the second part.
Will you cut the
Ball probe though. No, I don't think I will need. If I need to have a space in the middle ear, then I will cut it and lift the handle of malleus along with the tympanic membrane for reconstruction.
Beautifully coming out here.
So now I know I have not even lifted even a single bit of cholesteatoma there.
Right.
Forceps. ग्रीन थ्रेड आ रहे हैं.
बहुत सारे
Green-
green thread आ रहे हैं.
green
beautiful
thread आ रहे हैं.
dissection? Madhuri.
Thank you very much, sir. Thank you very much, friends. So now our disease is out.
Is there something near that lateral semicircular canal?
I'll just check it, and then we will think of reconstruction.
As soon as the head
Okay.
of-
So this is the, I'll show, sickle that. I'll just clear this part.
Yeah.
You can see this this is the tympanic portion of the facial nerve. Can you see there?
Yes.
And it is dehiscent. You can very well see. This is dehiscent. Can you see?
Yeah,
Yes,
yeah, yeah.
yes.
Yes.
So had we not been clear, we could have injured this, but once you know your planes and then you lift it, it does not happen. And this is the lateral semicircular canal. Can you
And
see
you're
that?
not, and you will not drill away the mucosa over it, right? That
Yes,
mucosa.
yes, yes.
There's,
So,
there is some granulation tissue under that.
yes, that is what I am clearing, sir.
This is what she's addressing it now.
अब देना साइड नाइफ देना
See,
this is
granulation
not
tissue.
cholesterol.
It looks
Yes, this is not. Okay, sorry.
Will
Sorry, you.
that granulation tissue left intact be able to settle down? You think it will settle down or you need to remove it?
Slightly hypertrophic part, though, I remove. Rest of the mucosa, if it is hypertrophic there, it will settle down. It should not be blocking the passage, na, granulation. So you, if it can be, it is possible to clear it, we will clear it. Okay. Now talking about ossiculoplasty and reconstruction of the posterior canal wall. Ossiculoplasty, because we have left that part of incus there.
Right.
So we can keep the tympanic membrane directly on it.
True, true.
Okay. So
Right.
give me sickle.
Madhuri.
Hmm?
Madhuri.
Yes, sir. So side. Hanji, sir.
Tympanic membrane is never contact with the long process of incus. Okay. So probably you have to reinforce that area a little bit. Or use a split thickness
Either
cartilage.
I can do a incus between head of stapes and malleus, interposition grafting. Then I'll have to remove this left whatever incus I left there.
Your assembly itna badhiya hai na.
Yeah, let
You
it
don't
be,
need to
let it
disturb that.
It's a good
I'm saying just piece up.
cartilage.
You are going to use a cartilage for the reconstruction of aortic wall.
Yes.
Okay.
Extend it inferiorly, make it like a relaxing chair.
Yes, you just extend it and make it that thinner, and that goes down. And upper part of drum is reconstructed with a partial thickness cartilage, which sits on the incus.
Okay. So give me now a sickle.
और जरा anterior ventilation दिखा मेरे को अभी.
हाँ जी बिल्कुल अभी दिखाती हूँ. सर्कुलर फिर देना बॉल प्रोब एंटीरियर वेंटिलेशन दिखाते हैं.
नहीं. See what people are talking to you, tensor cutting na. Sometime if you anterior to tensor जाओ, tensity बना.
हाँ वहाँ जाऊंगी. मैं बिल्कुल दिखाती हूँ सर. सारे तीनों pathways दिखाऊंगी. So there are 3 pathways actually. One is anterior ventilation pathway, which is anterior to the handle of malleus, and one is posterior, which is isthmus. So isthmus also has got 2 ventilation pathways, anterior isthmic and posterior isthmic. So first I'll show the anterior ball probe देंगे. So I'll go anterior to the handle of malleus there.
Bring the microscope back. Yeah. Thanks.
So I'm going there. There is a fold in 75% cases. This is called tensor fold. So it does not let the anterior ventilation happen. Now I am into the, can you see the ball probe coming from there?
Right.
Can you see?
Yes.
So I have gone through, there was no disease, but I have gone through this tensor fold. Can you see now ventilation, anterior ventilation pathway?
This is what I'm trying to emphasize. You have most often some fold in that area. If you don't look after it, over the years, again the infection pocket can develop.
But once you break this fold, that means it's gone. It will never come back.
No, it cannot, but it is not needed. Basically, it is a natural fold Which if it is not there, then the anterior attic gets ventilated from the supratubal area. But once the tensor fold is there, these cases usually tend to get retractions because
Sometime
anteriorly the
Sorry, sometime
anteriorly
Madhuri, sorry, yeah, you finish talking, then I'll talk.
yes
bolo.
anterior attic. Okay, sir. Sir, आप बोले हो गया मेरा. 40 देना.
Sometime I feel that whatever she took as the mucosal fold, I feel there's still some mucosal bands anteriorly. I'll drill that. I may take a part of the bone lateral to that. Anterior थोड़ा bone निकाल. हाँ, उधर क्या white क्या
सर
है?
इसको मैंने इसलिए रखा सर, जब मैं वो ट्रैगल कार्टिलेज रखने वाली हूँ ना, तो एक लेज रहेगा, नीचे स्पेस रहेगी इसके. मिडल ईयर स्पेस. सर दिस पार्ट है ना, दैट विल सर्व एज अ लेज. अपना कार्टिलेज नीचे नहीं जाएगा, यहीं पे रुकेगा फिर.
I understand that, but you can remove at this area. You can take bone on deeper. Here. This is the area to increase the ventilation pathway.
Okay.
Not that lateral one. You have to widen.
Okay, is it okay? Okay, sir.
It looks good, but if you widen it per millimeter or two, but it's not essential. It's just a first I'm making, I think.
Okay, अभी मैं क्या करती हूँ सर? I will just prepare the grooves for the posterior canal wall reconstruction. And if needed to maintain the middle ear space, I will just cut the processes so that handle goes along with the tympanic membrane, and I am able to put my graft nicely there. But if it is not needed, I'll not do anything. Okay, sir? So now drill de mere ko cutting back. So anterior groove and posterior groove I will make. Table थोड़ा और ऊपर कर दें. Slightly lift the table. करते जाएं. Please do it. हाँ, और. बस. So now I'm drilling a groove there in the anterior wall to hold the tragal cartilage. So when I'm drilling the groove, keep the anterior ledge intact, but keep drilling the posterior ledge because the cartilage takes a C shape. So it needs space there. Okay. So I'm not leaving a tunnel, rather I am creating a groove there.
This facial you want or
ये लो, ये एक बार इसको सक्शन बंद हो गया. सक्शन चेंज कर दें और वॉश पे देना अच्छा सा.
very good for the long run. In Indian practice, I will like these are always a temptation. It's not temptation. That is fine. But these sharp edges are there.
ब्लीडिंग है क्या?
बहुत बढ़िया है सर.
नहीं,
थैंक यू. बिल्कुल नहीं है, बिल्कुल भी नहीं है. ये थोड़ा दो ड्रॉप्स भी दिख रहा है तो शी फील्स की ये भी. पर जब बहुत अच्छा हो तो फिर 2 ड्रॉप्स भी दिखने में लगता है कि ना हो. तो भी कम करना. हाँ, थैंक यू वेरी मच. So I am creating a groove in the posterior wall. एक छोटा देंगे. थैंक यू जी. छोटा आसमान नहीं. हाँ, कोई डायमंड दे दो. जस्ट 15 मिनट्स मोर, फिर हमारा हो जाएगा. हाँ. 2 बूंद जिंदगी की. अभी पानी नहीं डालना, मैं थोड़ा ब्लीडिंग रोक रही हूँ इंटीरियर में. ओके. Okay. Now we'll see agar thoda aur, if I need to drill more, I will see after placing the cartilage. Lo wash dena. So now I'll harvest the tragal or the conchal cartilage. ये ले लेंगे. I'll try tragal आ जाना चाहिए वैसे तो. बड़ा चाहिए बहुत. Need a bigger one. Conchal will. है ना? Conchal लेंगे. So, Dr. Farida?
Right, Madhuri.
Okay, so this tragal seems if I take, I could, measure the, this is the length what we are going to get from the tragal cartilage. And it is quite wide there. I think it will not suffice. So I'll harvest the conchal cartilage.
Okay.
Local then. So for that, to avoid puckering the skin on the anterior side, I'll
Okay.
just give saline injection there.
Huh.
No, what is that? Just let that active open.
Okay, मेरे को forceps दे दे. कान पकड़ना forceps. हाँ ठीक है. मेरे को cautery दो. दिखाना. ठीक है. Okay.
Number one, lower the pressure in more than adequately, and most important, take away all the cells from the basket. You cannot have cells buried. Mucosa cannot be buried.
Madhuri, take your microscope in front. We are not seeing it. Microscope आगे ले.
Okay.
Center थोड़ा.
ठीक है sir.
Yeah.
पकड़ना. So seems a bigger graft is needed. अच्छा knife देंगे. Pause piece and knife. Just hold on there. Knife. Yes, pull it.
Lower the pressure more than adequately, so the ventilation system one thing. Otherwise, the doctor will.
Okay, ये किसी force, ये this you take the tooth forceps, give me plain forceps. Okay, okay. पकड़. मेरे को प्लेन दे दो forceps. Plain forceps.
If possible, centralized, please. Better.
Thank you, sir. एलिवेटर देंगे वो सेप्टल एलिवेटर. नाइफ या सिजर्स देते हैं. बड़े वाला से ज्यादा शार्प है। Now give me the elevator. Knife pen. ओके रिट्रैक्टर लगा दें दोबारा। सिजर भी दे देंगे बड़े वाले। ये दे दो, कोई नहीं, ये वाला ही दो। सिकल सिकल लो सिकल। पकड़ना इसको। अब मेरे को वो दें, क्या कहते हैं, व्हाट वी हैव टेकन इज ग्राफ्ट। हेलो।
Yes, Madhuri, we are there with you.
Okay, okay. So this is fitted nicely inside.
Yes.
Just now wash it and place the fascia and then the skin of the extraordinary canal
Yeah,
back.
Madhuri, you're not going to reinforce the incutostapedial complex?
सर नहीं, उससे ना वो बल्की हो जाएगा. We will leave it like that only because we are maintaining the stapedial tendon, everything is there. And I am not separating the handle of malleus even. So it will give strength to the side line.
It'll give more stability, you feel, if you don't disturb it.
I don't want. Because that will not be stable if it comes forward, and it will make this area very bulky. So I'm trying to create those flaps of tympanic membrane that will sit nicely on the.
Where the drum is going to be? Drum is going to settle on the cartilage.
But sir, for that, you'll have to.
And you see, I'm lifting it to overlap the graft what I'm going to get. Okay. अच्छा, अब वो ग्राफ दे दे. So many, hello, sir.
Right, bolo.
Madhuri,
Farida, many a times I have made a groove on the head of malleus and put it on the mobile stapes. It really works well and brings the airborne gap up to, closure up to 10 dB. So
Madhuri.
this is a good enough scissor.
So then it will be like type 3 only, no?
No, it is better than that. I mean, there is a interposition, there is a columella, ossiculoplasty. Now, this is not a interposition, this is columella. And when
Okay.
this is the natural incudostapital joint, at
Okay.
least something natural is happening there. We have
Right,
not disturbed that.
okay.
So, but the second thing can be I take away this long process and place the incus as interposition between the handle of malleus and the head of the stapes. I can do that. What is your opinion?
I think this is good enough, sir. Let it be. Let us
Correct.
see how it improves.
I can do that also.
माधुरी,
Yes,
माधुरी,
sir.
तू एक काम करना, ये जो तूने कार्टिलेज डाला है ना, उसको 2 मिलीमीटर नीचे स्लाइड करना.
आप मेरी बात सुनो. Listen, sir. If I place that cartilage, it is not going to become interposition ossiculoplasty. It is going to remain a columella ossiculoplasty. Then the natural bent is better than keeping another cartilage, and it will keep pushing the incus, which does not have any support other than the incudostapital joint. So unnecessarily that cartilage will put a pressure on the IS joint.
And
So
dislocate it.
cartilage is not going to serve anything further rather than making it bulky, but I can do what I feel is I can place a incus reshape between the head of the stapes and the handle of malleus. That is a 2 minutes job. I can do that. But it seems quite good enough.
If you're happy with this, leave it there.
Yeah.
If you're happy
So
with it,
you tell us, sir.
see,
No, I think
Madhuri,
you should just leave it, sir. It will give good hearing. I have done this.
I
with-
can do that. I can do that. The incus, I will reshape the incus and show you. Then tell me. It will give me 2
no,
minutes. I will at least do.
You do it beautifully, reshaping on, because I've seen you doing many times. But if you are satisfied with this nature's way of osteoplasty, keep it there. Don't do anything.
Artery देना.
Madhuri, sorry.
हाँ जी.
Suppose what you do, what you said is to put a piece into that little gap.
Ma'am, that gap is okay because we need some space also. If I put, I can put a cartilage piece.
No, I mean the gap on the top of the incus, the top of the incus between that and your graph. Just so that.
Okay,
so
I will do that. I will show you. I'll do that. I'll do that. That is going to put pressure on the incus, which does not have much support anywhere. So that cartilage I will take a cartilage piece and place it and
Madhuri,
show
you
you.
do what
Okay?
you're happy with. Don't listen to all of us.
Okay.
Do what you are happy
Forceps
with.
and
yeah.
knife. So I'll take a cartilage piece and try to place it there.
Sorry, I didn't mean that. I meant what you said, to put a little piece of bone between the two. That's all.
Oh, yes. Okay.
That,
So I don't do anything more.
no, you do what you would. No, don't do anything. What you want.
Yeah, leave it the way you decided.
You want me to place a cartilage, I can do anything what you, but I think that is good enough. His incudostapital joint was working very nicely. That's why the hearing loss was not much.
Right. So then don't disturb it, Madhuri. It will
है ना?
work.
It will work.
It will
Okay.
work.
So give me retractor. I'll place this graft there now to re-enhance the posterior end of the tympanic membrane because we have lifted it. So it slightly shrinks on itself. So I have to keep a graft there also to cover the cartilage part. दे दें थोड़ा गीला करके दीजिएगा. Too much सिकल ही दे सीधे. Too much dry fascia graft is not good, so I make it semi-wet. Okay. Okay. It's still too big. मेरे को scissor दे दें. Okay. बस हाँ वो लेती हूँ। चलो। मेरे को सिक्कल ही दो, आई डोंट यूज दिस। सिक्कल दे। हाँ दिस इज द ग्राफ्ट। नहीं कुछ नहीं करेंगे, ये थोड़ा इसको आगे पुल करना पड़ेगा आपको। द स्किन हैज कम डाउन। Yes, very good. एक बार मेरे को सीजर देना। हाँ So I have made two tongues out of the anterior part. One goes medial to the handle of malleus. Other goes into the superior to that. So one tongue goes medial.
Okay.
Oh, this suction is too big. Oh my God, this is too big. Suction छोटा दे दो फटाफट। नो छोटा कर दे एक बार।
Let's see what she's doing.
Huh? Where? You all are going? Yeah, come and stop here.
So now there is a enhancement of the tip. Can you see there? Nicely covered. The cartilage is also covered.
Yes, Madhuri, we can see that.
Okay, now I'll put the skin back. It's utare.
Gauri had a question, Madhuri.
Okay. The skin I am putting back.
Madhuri,
Yes.
posteriorly and inferiorly, there is little gap in that posterior canal wall.
Okay. Yes, absolutely right. Isko
what
pakadna.
will-
Well, I'll try to fill it up. Yeah, absolutely. I was also feeling that. एक बार forceps देना। Oh, absolutely right.
Medial to the annulus. आप थोड़ा लकड़ी दो मतलब कंडक्शन में घूमो, क्योंकि medial का कोई रोल नहीं होता।
Pickle. Is it okay now?
Yeah.
Okay. Leave it. Suture दे दें। Then with the speculum, I will place the skin exactly on the cartilage. Just put a one suture there, and then you can suture further. दे दो एक। Oh, sorry, सारे सुमन। Part3 देना।
ठीक वॉल भी कंस्ट्रक्शन किया ठीक है गलत हो और उसने अच्छे ये दिस फेल वेन्युलेशन तो वो ऐसा वाकड़ा तिकड़ा हो जाएगा नीचे ओके बट इफ इट इज अ गुड कैनल देन यू अच्छा कैनल फेशियल को हाथ में लगाया उसने ये कंस्ट्रक्शन फेल अच्छे कैनल हो गए मुझे दफड़ा नहीं है आपने फोन पकड़ा ना तो इफ यू आर डूइंग इनसाइड वाज ऑलरेडी कैनल होगा वो बोलते कि नहीं कर रहा वो शायद शब्द गलत बोल रही थी हां इंटर कैनल वाली मैंने जब मुझे तीन बार बोला तो मैंने इसलिए बोला कि सुन रहे थे ना हां ये ना ये आगे वीडियो पे तो हम नीचे तक जाने का वो फ्लैप ये सेट करते ना हमेशा सर लेकिन इंटर के बहुत
दूसरा सिरा पकड़ लो। रह गया कोई नहीं।
Madhuri, excellently done. It was a pleasure
Thank you.
watching you.
Thank you, Farida. Thank you for your kind patience and giving me time to explain. Thank you very much.
Madhuri, can you
Thoda
hear
lamba,
the
thoda lamba.
applause?
Oh, thank you. Thank you, Gauri. I enjoyed this session with my two beautiful friends, Gauri and Farida. Okay.
We would like to call Dr. Sanjeev Pete sir to felicitate Dr. KT Patil sir and Dr. Farida Wadia madam. Ma'am, 2 minutes.
Am I audible? तो केटी पाटिल सर को मैंने थैंक्स नहीं बोला, कोई नहीं, वहां जाके बोलना.
No problem. I am here only. Don't bother.
Oh, sir, thank you very much.
Okay.
Special inputs. Thank you very much. थोड़ा सा लंबा काटना, थोड़ा लंबा, हाँ, खुल जाते हैं ना.
हाँ, sir. देते 1 मिनट.
अब आप ना, मैं आगे बस थोड़ा लंबा. एक इधर लगाना, एक इधर लगाना. ओके, देन आई विल टेक द सेकंड speculum.
Yes.
Hello? Can you see I am placing back the skin what I lifted in a nice way, and there is no cut, no trauma to the skin. Kuch bhi instrument sharpened. So it is lying back on its original position, and that's it. Thank you very much.
You will be packing with this what?
With gel form pieces, first with few dry gel form pieces, and then I'll take the wet, soaked in antibiotic drops.
Have you any time
So
tried Merocell?
Merocell is, I keep in the outer part. Once I fill the cavity with the gel form, the outer 1/3 part is filled with a small strip of Merocell to keep the skin in place.
Okay.
So I do it in the lateral part. Otherwise, I feel the Merocell may press upon any reconstruction what I have done and may lead to the dislocation.